interesting session on the most important challenges we face in IVF, especially targeting the recurrent pregnancy loss, recurrent implantation failure, or the challenges during controlled ovarian stimulation. And without much ado, I now hand over it to our HOD, Dr. Kundavi ma'am. The Kundavi ma'am is a well-known faculty. Ma'am is a person of few words, and she wanted me to keep the introduction also few. She's our beloved HOD, and she is now the honorary secretary. She was honorary secretary in Oxy 2023 and chairperson elect of TAPIZAC. Over to you, ma'am, for the welcome address.
Thanks, Jovan, and a warm welcome on behalf of IRM and the Madras Medical Mission for this webinar on solving the Pandora box, because we know that whether it is going to be a genetic or an immunologist coming in a big way, and we don't even know an answer for recurrent implantations failure. So I welcome all the speakers in spite of the busy schedule. You are here, and I'm sure the delegates will definitely benefit from their expertise. So without wasting much time, Dr. Jovin to take over to introduce the speakers.
Thank you very much, ma'am. Thank you for the kind introduction. And the first and foremost talk today is on the challenge we face more and more nowadays, genetic polymorphism in infertility. To throw light on that, we have none other than Dr. Anuradha Udumudi ma'am. Anuradha Udumudi ma'am is a well-known name among us. She has a Chief Scientist Officer and Chief Medical Geneticist and Founder Director of Gene Tech Hyderabad. She has ample experience in fertility genomics, and she has designed world's first NGS-based genomic panels, and she has a lot of publications. She is an invited genomic expert for IMA IVF training programs as well. Over to you, ma'am.
Yeah, hello, I'm just trying to share my screen.
Sure, ma'am. You can see, ma'am.
Yeah, just make it a slideshow.
Sure, ma'am.
So are you able to see, ma'am?
Yes, ma'am. We are able to see now.
Okay. The whole screen is visible, right? Genetic polymorphisms in infertility.
Yes, ma'am.
Yeah. Yeah, I would like to thank Madras Medical Association and other associations who have been part of this program. Thank you very much for inviting me. It's my pleasure to share my experience with all of you. This is a very narrow, in the sense, focused topic on genetic polymorphisms in infertility. So I will be mostly talking about how these polymorphisms are identified and how they are useful in regular infertility practice to many of our practitioners who would want to achieve fertility as quickly as possible. So this slide basically is a very introductory slide. You all know about the chromosomes, and there are 46 chromosomes. And in all 46 chromosomes, we have what is called the DNA, which is a double helical structure. And on this double helical structure, there is a genetic code on the genes. There are multiple genes. There are 25,000 approximately functional genes. And on these functional genes, we have what is called the genetic code. And this genetic code would produce the proteins which perform different functions in our body. Similarly, reproductive physiology is also not very different. Reproductive physiology is a vast process, and there are multiple hundreds of genes that play an important role in producing the proteins that do different functions in our body for a successful reproductive cycle and for fertility achievement. Now, if we just look at the technology, I'm not going to take much time on this, but you all know that we have karyotyping, which is the microscopy test, and where all 46 chromosomes are visualized under the microscope. but it is a panoramic view of the genome, and it can only detect those changes that are more than 5 to 10 MB, if you can see here, which can be visualized under the microscope to identify problems with fertility on the chromosomes. Mostly the problems are balance translocations, which are present in parents, which would give rise to unbalanced gametes in the individuals and result in infertility. If you like, if you would zoom in much more, then you will see smaller changes through cytomicroarray tests, which are approximately 50 kb size. But cytomicroarray use in infertility is mostly on the fetal sample, because cytomicroarray does not detect balanced translocations, which are the most common problems in infertility. So then we also do prenatal FISH and QFPCR to identify targeted chromosomal problems. This is also done mostly in the fetal sample and not in the parental sample. If you zoom in much more into this chromosome and want to look at the gene or the changes at the gene level, this is done by sequencing. Now, sequencing can be done for the targeted single mutation. You can target, just look at this mutation, TAT has become TCT. So there is one change of the base, A has become C, and this has resulted in an abnormality. This can be done by targeted mutation, where you are checking a single mutation, or you can sequence the complete gene, which is single gene sequencing, or you can do multiple gene sequencing. That is where the NGS or next generation sequencing comes into picture. You must have heard the term whole exome sequencing. One second, I think I'm hearing some sound. Yeah. So whole exome sequencing, this can be actually usually whole exome sequencing is done for individuals with genetic abnormalities, but NGS is also used to look at multiple genotypes that are associated with infertility. I will talk a little bit about that. So this basically shows you how technology is useful. And the genetic technology, as rightly said in the beginning, is plays an important role in identifying problems with infertility, followed by preconception. For example, you can do carrier screening of couple to identify risk for offspring. You have multiple tests that are associated with pregnancy, ultrasound abnormalities, fetal abnormalities, multiple tests associated with pediatric and newborn testing, and then late onset diseases. Today, our concentration will be purely on infertility. There are multiple genetic investigations that are available for infertility at this point, and every test has its own advantages and disadvantages. And here is the doctor always wondering what else could be wrong, because we have done everything right and the tests are showing that there is no problem. What else could have gone wrong? I have listed a few investigations with their limitations here. Clinical parameters, of course, are both hormonal and ultrasound abnormalities, and these serve as a broad guideline, and they never diagnose the root cause of the fertility problem. Karyotyping is culture-based and microscopy, as I already discussed, and but less than 10%, I would say less than 5% of cases come back with a problem. Otherwise, 95% of the problems of the results or the reports show that the karyotype is normal. So the diagnostic yield is very, very low. And then if we are using PGTA or PGT-SR, SR is where the structural abnormalities are tested of the parents, and A is for aneuploidy. If we are using A or SR on embryos, it's a DNA-based test, and NGS is used for PGT. But it only looks at aneuploidy screening, and transfer of euploid embryos does not guarantee live birth. And cost is also an issue here. These are some of the limitations of euploid embryo transfers. HLA sharing is done for many of the people with recurrent pregnancy losses or implantation failures, and KIR genotyping in case of you would want to test the compatibility of the embryo with the mother's uterine NK cells. And now this is done by different methods, both by NGS and PCR. And it is a very good test to identify what is the risk for recurrent pregnancy loss and implantation failure so that immune modulation can be provided. However, it only addresses the immunogenetic component of infertility and not the wider range of genetic problems. Endometrial receptivity assay is also done by NGS. Here, the gene expression is studied, but it is only restricted to current cycle, and then the cost is also prohibitory. Carrier screening, which infertility clinics often use, which is a whole exome based sequencing based test, it only identifies risk for genetic disorders, but it does not give any useful information for infertility and ART issues. So with that, let's move on to identifying polymorphisms or risk genotypes. This is done in our laboratory by two tests called gene femina and gene andro. As the name indicates, femina is for female and andro is for male. This genomic fertility analysis looks at multiple genes, hundreds of genes and thousands of variants to identify risk for fertility, infertility, and recurrent pregnancy losses. Before I go into the details of these investigations and cases, let's look at what is a mutation and what is polymorphism. This is a very small but an important aspect that clinicians should understand. A mutation is something where I mean, you all know this. I give the gene has an exonic part and the intronic part. Exon is the expressing part, which is in the blue, and intronic is the space in between the exons, right? But the changes in both exonic regions and intronic regions can cause problems. A mutation is usually in the exonic region, which is the expressing part, and the normal protein is not produced here. You have either an abnormal protein or you have no protein at all. And in such a scenario, there is usually a very drastic genetic problem or even an infertility situation, which is very, very severe, can appear. But in terms of, in the case of polymorphisms are called as risk genotypes. What happens is that the normal protein just becomes altered. Either the production is lessened or increased, but it does not become abnormal. And because of this alteration, the risk for the individual increases, but it does not result in a genetic severe problem. So infertility as such is not a genetic disorder. There is a risk for fertility issues which can be prevented in many of the cases. And how do we do that? And what we have done in our last 8 years is that we have tested around 10,000 cases of infertility and recurrent pregnancy loss. And we have come up with these products, Gene Femina and Gene Andro. These are our IP. And what do they actually do? There are actually 3,000 genetic variants that we have included in around 300 genes, and it evaluates complete 360-degree fertility problems, and also gives ART implications. Now, if you look at this diagram, it shows that the main idea is to identify the root cause. Why is there fertility problem? And once you know the root cause, the test also provides drug implications, in the sense what drugs are suitable for treatment, and ART protocols are also suggested based on the genotype. I'll show you some cases here. And then the drug and surrogacy recommendations are also given. So all in all, it's a 360-degree evaluation, and then it gives you ART implications and drug implications so that fertility can be achieved as quickly as possible. Multiple publications have been presented by me and my team. In last 2 years, we have published around 8 papers, and first presented in 2019 at ACMG, American College of Medical Genetics, and then followed by that multiple papers have been produced, and which are very, very important for Indian population. Now let's look at Gene Femina. Gene Femina gives you a wide coverage of fertility problems in female. It covers ovarian and uterine conditions, like it looks at premature ovarian insufficiency, polycystic ovarian syndrome related genetic problems, oocyte count quality, endometrial condition, the risk for uterine fibroids, etc. And then the second section is the fertility and ART implications, where it talks about unexplained infertility, poor ovarian response or OHSS risk, empty follicle syndrome, fertilization failure, zygote arrest, embryonic developmental problems, etc., including recurrent implantation failure related issues. In third section, the pregnancy loss and complications, it looks at RPL cases, which are both thrombophilia, immune dysfunction, oxidative stress related, and also complications such as fetal NTDs, ectopic pregnancy, hydatid molar formation, preeclampsia, etc. So all these are covered so that the physician can get a peek into the risk at various levels and will be able to help the patient until a successful live birth. So let's first move on to controlled ovarian stimulation, which is very, very important, crucial first step in our treatment for fertility. And of course, every physician's dream is to get 15 oocytes, good ones, but that does not happen always. We get poor response with less than 5, suboptimal, good response, and in some cases, hyper response also. And AFC and AMH are the most important parameters that clinicians consider, for including estradiol sometimes. But the way forward is to look at the genetic evidence and not just one FSHR or LH genes that are well known in controlled ovarian stimulation association, but there are 20 genes that are associated with COS. And there are 6 genes associated with ovarian hyperstimulation. And gene femina looks at all this and it derives a odds ratio, meaning what is the is there a 2x risk, is there a 3x risk, or is there just a risk with one genotype? And then it tells you what are the specific drug selection and dosage guidelines that you can use to increase the output of controlled ovarian stimulation. Here I just compared 2 cases, so both of them with the poor response to controlled ovarian stimulation. In the first case, they have 2 failed IVF, IUI, and 1 failed IVF. The quality of the oocyte was very, very poor, and we identified that there is LHCGR gene. Those who have already been using the panel, gene femina panel, know how well this LHCGR gene variation is picked up, and also the outcome is so good when you change the course of your treatment. When we see LHCGR gene variant, it gives you a slow response, of course, and then exogenous recombinant LH stimulation is highly favorable. With this recommendation, the recombinant LH was given, and 8 oocytes were retrieved and 6 embryos were formed. This single embryo transfer resulted in pregnancy and then followed by live birth. In the other case, we see that there is IVF failed, poor response. 2 genotypes, one in ESR1 and the other in FSHR, are identified, which of course correlates with poor follicle and oocyte quality, along with poor response, and high gonadotropin dose was recommended. And 14 oocytes were retrieved and 8 embryos formed with high gonadotropin dose treatment. Single embryo transfer again and live birth recorded. So the live birth is directly proportional to the outcome of controlled ovarian stimulation, and by modulating the controlled ovarian stimulation based on the female's genotype, you will get better results. This is one of the paper that we have published, I think about 2 years, 1.5 years back, of around 500 sample size, where we have shown the most common genes associated with poor ovarian response. I have not listed all 20 here, but there are many. And FSHR gene is only present in 15%. So because mostly people ask me, do you do FSHR gene variations, or gene polymorphisms. It's not just FSHR gene polymorphisms. There are multiple genes associated with controlled ovarian stimulation. And based on the number of genes, again, the risk would vary. And in this particular study, we have demonstrated how the suboptimal group has been moved to good responders by modulating the controlled ovarian stimulation protocol based on genetic variants. So this is presented in also in ASRM 2025. Next, we'll move on to oocyte maturation defects, which are also a big challenge in infertility clinics. Oocyte maturation defect, although we call it oocyte maturation defect, it also includes zygote maturation defects and early embryonic maturation defects and developmental problems. It can result in poor oocyte quality, it can result in fertilization failure, it can result in recurrent IVF failures, early embryonic developmental problems, and also early pregnancy losses. And there are 20 types of oocyte maturation defects. And you can see examples here given as ZP1, TUBB8, ZP2, ASTL. They all result in certain types of oocyte maturation defect, and ART recommendations are given, and modulation of the protocol is necessary when you see this oocyte maturation defects. Here I have compared two cases again. In the first case, 3 ET cancelled, embryo transfers cancelled because of embryonic arrest. We found a pathogenic variation in the gene TUBB8. It's also called TUB8, but there are several TUB genes, TUB4, TUB3. These are also associated with oocyte maturation defects. And this TUB8 causes oocyte maturation defect type 2. It disrupts the spindle assembly, and then it makes the cleavage of the embryo very, very difficult. Because of uncleaved embryo, there are problems, including fertilization failure, and which is much prior to the embryo formation. And OD cycle is optional here. It is very, very difficult for a female with TUBB8 to conceive with self oocyte, and therefore oocyte donation is optional and can be. This is how you can actually recommend donor recommendations based on the evidence. In the second case, you can see empty follicles on stimulation. Here we found a pathogenic LHCGR variant, which results in genuine empty follicle syndrome. This is very, very important for physicians to show why there is empty follicle, and this gene variation results in LH resistance, and even in these individuals, OD cycle is optional and highly recommended actually. Now we'll move on to recurrent implantation failure or pregnancy losses. You can see that there are multiple genes associated with pregnancy loss here. For example, thrombophilia, there are 20 genes. Immunology, there are 30 plus genes. The genes that affect placental and trophoblast environments are also, environment is also there. Anti-apoptosis. And then, of course, the list goes on with pregnancy complications of preeclampsia, ectopic pregnancy, even hydatid molar pregnancy, NTDs. Aneuploidy risk is also dependent on sometimes maternal and paternal genotypes. And of course, smaller ones like IHC are also having genetic predisposition. This is one of our paper which was published in an international journal, where we all know that when we talk about thrombophilia, we are mostly talking about factor 5. But factor 5 gene variation is very, very rare in Indian population. And so as long as we stick to Western guidelines and continue to provide targeted testing of those genes which are being reported in Western population, we will not be able to do much good for our patients. So what are the genes that are associated with thrombophilia related pregnancy loss? Inherited thrombophilia, I'm not talking about acquired thrombophilia, are these genes: MTHFR, MTR, MTRR, PROZ, VEGFA, factor 13, which is very, very prevalent compared to factor 5 and factor 2. So there are multiple genes associated. Based on the gene, the therapeutic anticoagulant dose or even some drugs like metformin and their efficacy on treatment will be provided in the report based on the literature and also the research that has been done internally on Indian population. And this is anybody who wants papers, you can just email me and then I will send those papers to you. Moving on from thrombophilia, let's look at immune dysfunction. We all know that pregnancy is pro-inflammatory, followed by anti-inflammatory, and then again a pro-inflammatory stage, and multiple genes associated with pro-inflammatory cytokines and anti-inflammatory cytokines. These IL genes are many, and any mutation or any polymorphism on these IL genes could result in immune dysfunction. And we know that the woman is predisposed for immune dysfunction because of these gene variations. It is important that the immune modulatory therapeutic solutions should be provided. I will not going to talk about what therapeutic dose, but sometimes if there is literature available that this particular gene variant is associated is giving better results with this particular therapy, then it will be mentioned in the report. For example, if intralipid is something that really works, it will be mentioned, or if IVIG has been proven in past, it will be mentioned. Otherwise, it's the choice of the physician or the fertility specialist to decide what is the best immune modulatory therapy to be provided to the patient, because you already know that this patient has a high risk for immune dysfunction during pregnancy. So that's the point. And I've just again compared a few cases here. First case of 3 recurrent pregnancy losses. You can see that there are multiple genes associated with pregnancy loss. All the three, MTHFR, MTR, and PROZ, all the three are associated with thrombophilia, and therefore the risk has gone up to 5-fold. And in these conditions, you have to give a therapeutic anticoagulant dose. Of course, MTHFR, MTR play a role in folic acid metabolism. So preconception folic acid with vitamin B12 is must. And they all, PROZ adds preeclampsia risk. So prevention of preeclampsia is important. MTHFR has an indirect role on aneuploidy also. And therefore, either fetal screening or embryo screening is important by PGTA, or at least after conception by a very strong NIPT, and ultrasound follow-up is required for individuals with MTHFR mutation. And if you see the other case, it is also recurrent pregnancy loss with failed IUI. We see that there are two genes, IL-10 and IL-21 associated here, and this results in immune dysfunction. So anti-inflammatory immune support is recommended in this individual. The physician has successfully provided this treatment, and it resulted in a live birth in both these cases. Uh, Two more cases on recurrent pregnancy losses. In this case of 2 recurrent pregnancy losses with PCOS, we see MDM2 and PAI1 genes. MDM2 is associated with oxidative stress. Just by giving a good supplementation of antioxidants will help this individual and benefit this individual uh, tremendously. I mean, you must have noticed that antioxidants are given for every individual, but they work in some and they don't work in some. The patient with MDM2 will receive antioxidant supplementation very well. And because of the PCOS risk, the PAI1 gene is also associated with PCOS, but it's also a thrombophilia related risk. So thrombophilia management and metformin is very good in these individuals. Metformin has proven to give better results in individuals with PAI1 gene. So that's how success was achieved here. In this case of RPL and failed IUI and IVF, we saw a very important gene called KHDC3L. Now, this gene does not let the embryo cleave properly, and it inevitably results in a pregnancy loss. It is highly recorded in hereditary molar pregnancy. It's also recorded in RPL, RAF, and stillbirth. Therefore, in these individuals, oocyte donation cycle is optional and patients can be counseled accordingly. I may not be going into details of HLA sharing because I see that the very next lecture is on immunology related. But then HLA sharing is very important in prevention of recurrent pregnancy loss. This is not a polymorphism topic, so I'm not going into details. And I will move on to the last section of the female infertility, which is premature ovarian insufficiency. We know they're noticing a lot of patients with low AMH these days. There are 21 types of premature ovarian insufficiency as far as genetics is concerned. Many genes like BMP, 15, NR5, A1 are associated with it. And when you see that the woman has a predisposition, most of these women may have 2.5 close to 3 AMH, but then they are aging fast. So in these individuals, then fertility preservation probably is one of the most important a recommendation that fertility specialist can give. Here in this case, the individual with FOXL2 has premature ovarian failure type 3, and PRP treatment has been already proven as a good uh, treatment modality in these patients, and we have recommended the same. In the other case, estrogen replacement therapy was very helpful where there is gene ERCC6, and this patient also actually conceived by donor oocyte at a later point. Now, I will move on to gene andro, which is the male related. So, gene femina, just to summarize, we have looked at multiple gene variants which are both polymorphic and also polymorphic variants and also mutations which result in severe form of fertility or risk genotypes which are associated with higher risk. And by identifying these and then modulating your protocol and giving recommendations to patients that will improve their outcome and also make the fertility treatment faster is very, very important. So now let's look at the male part of the polymorphisms, which are looked at by a test called gene andro. Again, if for male infertility, there are multiple tests that you all are probably following. Karyotyping, again, as I said, not a very good diagnostic tool, but still it is the basic test that must be done because we don't want to miss balanced translocations. And then some people do AZF gene deletions for azoospermia, and I'm going to show you how AZF gene prevalence is very, very low. And sperm aneuploidy, a few physicians request, and some of us do CFTR in case of non-obstructive azoospermia. And all of them have a very poor diagnostic yield. And a gene fem andro covers all types of spermatogenic failures, starting from azoospermia, oligospermia, teratozoospermia, MMAF, sperm maturation defect, flagellar defects. It also covers CFTR, AZF gene deletions. It includes erectile dysfunction, fertilization failure, zygote once the sperm reaches the female. Even there, the defects could be fertilization failure, zygote arrest, embryonic arrest, even recurrent pregnancy losses. So all these are part of gene andro panel. Just let's look at these two cases of a patient with primary infertility with non-obstructive azoospermia, and the other case is also very similar. In the first case, we've seen that AZF gene B region is deleted, and in the second case, we saw that the AZF gene C region is deleted. So AZF gene deletions are part of gene andro. So we look at AZF genes, and when there is a deletion at the region B, these have poor prognosis, very poor prognosis, and virtually certain deletions have zero chance of conception. And in those cases, TISA may not be the best option to go for, and sperm donation can be recommended. But if the individual male has a deletion in the region of C, then there is good prognosis reported with TISA. and TISA with ICSI is a better option if this is deleted. So based on the genotype, your course of action for that particular male will differ. This is an example of AZF gene deletion. But how many of AZF gene deletions are reported in azoospermia? That's the question. So the question here, it says that out of 150 cases, we have seen only 3 cases associated with AZF gene deletion, and there are multiple other genes like TAFB, then TEX11, TEX15, NR5A1. All these genes are associated with non-obstructive azoospermia. Based on the gene, there might be an implication on how to recommend the course of treatment for these males. And in many cases, and in some cases, sorry, a donor gamete, donor sperm option will be inevitable to be discussed with the patient. Here, I just showed 2 cases of non-obstructive azoospermia again, where AZF gene deletion is normal, there's no deletion. But in first case, we have a gene called MEIOB gene, which results in spermatogenic failure type 22. And here you have cryptozoospermia, and prognosis with sperm retrieval is very, very low. It's been published in the literature. So once we provide that information to you, you can very well start discussing sperm donation option with the patients. And this patient conceived by sperm donation ICSI. In the other case, where we see a ZMYND15 gene variant, this is associated with type 14 of spermatogenic failure. It results in severe OATs in most of time, but TISA for sperm retrieval has been reported in literature, and therefore this patient was advised TISA and they continued with the treatment and they have conceived. In both these cases, as I said, AZF gene deletions were not there. Without knowing this information, the clinician would have been again, with no diagnosis. So the point to convey is that diagnosis is important to understand the course of treatment. Here is one case of severe OATs. This actually is the case that demonstrates the pharmacogenomic implication of male infertility of the gene FSHR. This male was identified with severe OATs, 2 IUI failures, 2 IVF failures. He had a genotype on FSHR gene, and when you have an FSHR genotype reported, you can give a recombinant FSH treatment for the male for 2 cycles or sometimes 1 cycle, and it will drastically improve the seminal parameters and the ART outcome. So this is a case presentation. Anybody who would like to know the dosages and how we have used in this particular case, you can write to me, and I'll send you the paper. We've also presented at ASRM 2021 around 150 cases of this particular male infertility problem. And here self-gamete ICSI, and sometimes natural conception also was possible after the treatment of recombinant FSH. So this is the pharmacogenomic implication that can be seen here. In this picture, you can see asthenozoospermia, and also the sperm here are unable to penetrate the zona pellucida, whereas the sperm on the other side are able to reach the oocyte well and fertilize. And this type of problems where there is a motility issue, especially the hyperactivated motility disruption, happens because of a gene variant called CATSPER1. And when this gene variant is present, ICSI is the answer. So there is no point doing IUI in these individuals. So this patient, you can clearly see it was asthenozoospermia. They made the sperm select. They did IUI 4 times and it failed. It wouldn't work because it cannot actually penetrate the zona pellucida. So in these cases, it is better that you take up ICSI rather than IUI. And this gives a very good information to not do IUI. This is a case of teratozoospermia where we have a gene variation in ACTL9. Now, the ACTL9, what happens is it causes spermatogenic failure type 53 with acrosomal functional defect, and it has a poor oocyte activation problem. So because it cannot activate the oocyte well, you need to provide assisted oocyte activation in these individuals. So these can be planned ahead of time so that you don't you actually save time and fertility is given as quickly as possible. So this is assisted oocyte activation done for this individual, and they have conceived successfully and live birth recorded. This is the case of acephalic sperm. You can see the acephalic sperm here, and caused by the most important gene in spermatogenic failure, SUN5, and it results in spermatogenic failure type 15. And these individuals, if you see that there is a neck head connection that is intact, and maybe the DNA is present, it is possible to use them as by cell sperm selection and NXE. But most of the time, a sperm donation is the recommendation for many of these individuals. This a particular man conceived by sperm donation. So, why do you have to use gene femina or gene andro, genomic fertility analysis, and look at all these hundreds of genes and the polymorphisms associated? Because you don't want to be doing different tests and at different stages, one for stimulation, one for implantation. So if you look at everything holistically, you will be able to provide treatment end to end. And you need to know root cause diagnosis. You're looking at drug correlations, what ART protocols to adopt, when to actually recommend donor gamete, how to counsel the patients based on evidence, and of course, to increase success of fertility treatment. The sample should be sent in 3 ml. 3 ml of blood is sufficient. Sometimes from other countries, we get buccal swab also, but within our country, I think blood is fine for transportation, 3 ml of EDTA. All tests are done at Hyderabad in my center. And transportation should be done within 24 to 48 hours, and turnaround time is approximately 3 weeks. We ask for a detailed history of fertility history of the patient so that we correlate and we add weightage to certain clinical parameters so that we get better correlation and results that will help physician diagnose and modulate their protocols. The report approximately looks like this. First page, this is the latest version of our report. People who probably are using before got a different look of the report. This is the first page gives you the gene variants identified and what needs to be done just with the recommendation. Then the following pages will give details about each section and also the variants in detail. If HLA sharing is also recommended along with the gene femina, the information is also provided in here. What is the last slide and what is most important is genetic counseling. Although the reports are self-explanatory, most of the time physicians can explain themselves, but if patients have any question about why to take the test and then to understand the test results, genetic counseling is very, very important and it can be part of your practice. So with that, I think I can close it. Don't know exactly how much time I took, but if I have crossed 30 minutes, I apologize for the same. I thank you for this opportunity. And if you have any questions, I'll be more than happy to answer now or at the end of the session or however you think is important. I'll stop the share. Is that fine?
Yes, ma'am. Thank you, ma'am. Yeah, few
And of
questions
course,
that
my email is anu@genetech.co.in. This will actually, you can email me and I'll send you all the papers required.
thank you, ma'am. Thank you for results presentation, stepwise detailing, and emphasis on the counseling part, ma'am. We have a few questions, ma'am.
Yes.
When a donor patient who is apparently fertile shows cleavage arrest, what has to be done?
So the donor is the male or female?
Female donor, ma'am, egg donor.
Uh, So the problem probably is in the donor oocyte. So we need to investigate the donor to be able to understand why there is cleavage problem.
Ma'am, then the next question is when to suspect and test for each genetic test, ma'am. How to specifically ask for?
How to?
Is
How
it
to?
always a panel of tests we ask for, or specifically when we suspect and we ask for?
So, as I said, there are multiple tests, and this particular discussion today on gene femina and gene andro is purely for identifying the root cause of infertility in male and female. Uh, so, if you ask for gene femina, you will have information on controlled ovarian stimulation, you will have information on risks for implantation failure and recurrent pregnancy losses and the other things. But you will not have information about the chromosomes, right? Chromosomes are part of karyotyping. So karyotyping has to be done separately. If HLA sharing has to be done, that has to be done separately in cases where there is consanguinity, where there is recurrent pregnancy loss or implantation failure. That is also separate because gene femina and gene andro look at the genes, they sequence the genes and they identify the mutations and polymorphisms on the genes associated with both infertility and pregnancy loss. And of course, if someone has a family history, you can do carrier screening. If the fetus is lost, you can do cytomicroarray. So there are multiple other tests that are done, but this particular gene femina and gene andro panels are purely done to handle infertility in the clinics.
Well, many have asked about the cost or the charge for gene femina.
So gene femina, gene andro are 20,000 rupees tests each.
Each. Okay. And what is the assisted oocyte activation spoken about?
So assisted oocyte activation is done in vitro in the sense because the oocyte is activated out inside the female body, but you actually take the oocyte outside and then you activate it, which helps in fertilization. Many of the infertility specialists would know that.
Ma'am, someone has asked your mail ID.
Yeah, can I type it in?
Sure, ma'am, you can type it in the chat box, or do you want me to do, ma'am?
Yeah, I'm typing and I'm
Okay.
also reading it out. Anu,
Actually,
ANU at genetech, genetech.co.in.
yes, ma'am. Ma'am, they want to know the mode of transportation of blood needed for this genetic test, any specifications.
It
You
is at
told about
room
it. Yeah.
It is at room temperature. Just collect 2-3 ml of blood in EDTA vacutainer. And actually, we have a logistics program. We don't have anybody coming and telling you what the test is all about, but we have logistics that we can arrange. So if you collect the sample, we will be able to pick up from anywhere in the country.
Thank you very much, ma'am. You have come to the conclusion.
Most
Thank you,
welcome.
ma'am. Thank you very much for it.
All right. Thank you.
Thank you, ma'am. Moving on. Sahiti, can I have Ramakrishnan sir's CV? The next talk we have on recurrent implantation failure, the immunology behind it, made simplified. For that, we have a eminent senior consultant rheumatologist of Apollo Medical Center, Dr. Ramakrishnan sir. Sir's experience in rheumatology spans more than 44 years. He is specifically interested in recurrent pregnancy loss and recurrent implantation failure, with ample experience of about more than 2,000 patients, I would say, with obstetric antiphospholipid syndrome. Over to you, sir.
with
this.
Share screen.
Okay.
Here, share.
Is it
To open it, no?
It's not showing here.
You
Will this
open
do?
it and share.
No, so we just do entire screen. Why it's not changing? Okay. Okay.
We can see your screen now, sir.
yeah.
Yes, sir. We can see it in full share mode. You can go ahead, sir. Good to go.
With a good morning to those who are just getting up from their sleep. Good afternoon to those who continue to be awake. And good night to the majority who will get into sleep for their afternoon nap. I start my verbal assault on you on the topic recurrent implantation failure, immunology simplified. Dr. Kundavi and her team have been kind enough to give me this topic, but it's something a little less tough than understanding Donald Trump's brain. The primary objective of my presentation today is to demystify the immunological aspects of recurrent implantation failure and provide a simplified framework for clinical decision making. The topics which I'll be covering are clinical reality, immunology basics, diagnostic framework, clinical management, and practical applications. What is the clinical reality? The formal definition of recurrent implantation failure. RAF failure is the failure to achieve clinical pregnancy after three or more than three high quality embryo transfers or more than two egg donations. The Escher definition of RAF is thresholds now adjusted for embryo euploidy and maternal age. And the key metric now is failure after two euploid embryo members transfers is a strong indicator for further workup. The clinical presentation of a person with recurrent implantation failure. It's actually a frustrated couple. Beyond the numbers, RIF presence represents a significant psychological and financial burden, driving a demand for answers that embryonic quality alone cannot provide. I've seen patients with 13 pregnancy losses and 14 pregnancy losses, which is really, in fact, absolutely pathetic to encounter in a consultation room. And you get quite depressed that God is so nasty to some couples. The clinical presentation of these patients can be repeated negative tests despite optimal endometrial thickness and high quality blastosis, biochemical pregnancies with a transient increase in human HCG above the rapid decline, and then early losses can be preclinical or very early clinical pregnancy losses. The etiology of RAF is multifactorial, but I shall not discuss about embryonic factors, endocrine and lifestyle and uterine factors because you know them better than I. I'll be concentrating mainly on the immunological factors. The immunological factors, the focus will be on immune dysregulation at the interface, maternal fetal interface. Markers, you have cells, the NK cell activity, the HLA system, and the cytokine balance. And with respect to autoimmunity, antiphospholipid antibodies, ANA, and antithyroid antibodies. Now we have two limbs of the immune system. We have one which is called the innate immunity, the second one which is called the adaptive immunity. We're coming down to immune immunity. The most important properties or qualities of the innate immunity, it's an immediate defense mechanism. Example, the process of inflammation. It's a non-specific response acting within minutes to hours of exposure. Second important quality of innate immunity, there is no memory at all. The response remains the same regardless of repeated exposures. Who are the key players in innate immunity? The key players are macrophages and neutrophils. The macrophages functioning as antigen presenting cells like the dendritic cells. Then you have the natural killer cells, which play a very important role in the process of pregnancy, implantation, and further continuation of pregnancy. The complement system is also a part of the innate immunity, where it is responsible for magnification of the inflammatory response. It plays a very important role in recurrent implantation failure. Adaptive immunity. Adaptive immunity, in contrast to innate immunity, the response is absolutely specific, highly targeted defense that develops over days to weeks, something like the drones which are seen in the West Asia war. Adaptive immunity, another important quality is immunological memory, providing long lasting protection and faster response upon re exposure. A classical example will be vaccination. Who are the key players in adaptive immunity? The key players in adaptive immunity are T lymphocytes, which mediate cell mediated immunity, B lymphocytes, which mediate antibody mediated, plasma cells, which later become B lymphocyte, whose origin is from the B lymphocyte, antibodies, which are produced are IgG, IgM, and IgA, which mediate humoral immunity. What is immune tolerance? Immune tolerance is the capability to distinguish self between self and non-self. The fundamental ability of the immune system to distinguish host tissues from foreign invaders. It's a very active process. Tolerance is not just ignorance, it is not just passive, it is an active suppression of harmful immune responses, and this plays a very important role in placentation and further continuation of pregnancy. Systemic balance. It is maintained by specialized cells called the T regulatory cells and the signaling molecules called as cytokines, which are nothing but intercellular messengers. So, when it comes to immune tolerance, it's the capability to distinguish between self and non self. It's an active process of tolerance, and there should be a systemic balance, which is done by specialized cells, Tregs, and signaling molecules, cytokines. The reproductive paradox. If you take the fetus, the embryo is genetically 50% foreign to the mother paternal DNA. It's a semi allograft and it has to withstand in a hostile environment of the uterus. The challenge is, how does a mother's immune system tolerate this invader while remaining competent against pathogens? When you keep reading about the immunology of pregnancy, it's quite fascinating how we survive such a hostile environment within the uterus. But now, worst is after we come out of such a hostile environment, the environment outside is still more hostile. So I think I feel like going back to my mother's womb after seeing what's happening in the world today. The uterine microenvironment. The uterus is a specialized site, a unique immune environment where tolerance is actively prioritized over rejection. And local versus systemic, the immune response in the uterus can differ significantly from those in the peripheral blood. The uterine microenvironment. It is different. What is happening outside the uterus and what is happening outside the uterus, we have systemic immunity, surveillance, and defense. Primary goal is to identify and eliminate non-self pathogenic, example pathogens and tumors. Aggressive response. Foreign antigens trigger a robust inflammatory and cytotoxic attack, and HLA restriction. This is very important. The HLA system, matching system, required for tissue acceptance. Example, the role of organ transplantation. Uterine sanctuary. It's an immunological paradox. Immune responses in the uterus can differ significantly from those in peripheral blood. Actively tolerates the semi-allogenic fetus 50% paternal DNA. Who are the specialized actors in the uterine sanctuary? The dominance of the uterine NK cells 70% and the M2 macrophages for tissue remodeling and vascularization. Inflammation is very controlled. In fact, inflammation is timed implantation but suppressed for maintenance. It's a calibration of the inflammatory response taking place within the uterus. So, the clinical insight with respect to the uterine microenvironment is the local microenvironment is different from systemic. Hence, systemic immune markers, blood tests are often poor surrogates for the complex localized molecular conversion happening at the maternal interface. That is why the blood tests like the peripheral NK cells may not actually replicate what's happening within the uterine endometrium, so they are not very useful. The immunological landscape of RAF and RPL. We have so many factors which are here. The first is the cytokines, the intercellular messengers, namely the Th1 and the Th2 cytokines. The second is with respect to the HLA system, the human leukocyte antigen system, which plays a very important role in organ transplantation and distinguish between the self and the non-self. You have the microbiota, the lactobacillus predominance in the genital tract, and then you have the natural killer cells, which are members of innate immunity, which mediate very important, not in the uterine endometrium. And then you have the T and the B lymphocytes, the T cells mediating cell-mediated immunity, the B lymphocytes which mediate humoral immunity, and that they are members of the adaptive immune system. Then after that, you have the B macrophages, which are very important cells. Phagocytosis is a very important rule. And then you have the dendritic cells, which are antigen-presenting cells. These dendritic cells are antigen-presenting cells in the adaptive immune system. They play a very important role in association with the HLA antigens. So first we shall discuss one important key factor, the cytokines, the intercellular messengers. What are they? They are intercellular messengers produced by immune cells and trophoblasts that regulate inflammation, tolerance, implantation, and placentation. You have two types of cytokines. One hand, we have the pro-inflammatory cytokine, and on the other hand, you have the Th2 anti-inflammatory cytokines. What are the pro-inflammatory cytokines? The tumor necrosis factor alpha, gamma interferon, and IL-1, IL-2, and IL-6. These are the predominant pro-inflammatory cytokines which play a very important role in pregnancy. They are essential for defense, but they can be hostile to the embryo in excess. The Th2 anti-inflammatory cytokines are IL-4, IL-10, and IL-35, and transforming growth factor beta. These are responsible for modulating the immune response and suppressing the immune response. They promote tolerance and support successful implantation. The clinical application would be implantation is a controlled pro-inflammatory state where IL-1, IL-6, and TNF alpha promote tissue remodeling and early embryo endometrial communication. Coming down to cytokines again, the messengers, you have two paradigms, Th1 and Th2 paradigm. Th1 is pro-inflammatory. When I say Th1, remember pro-inflammatory, and when it is pro-inflammatory, always remember TNF alpha, gamma interferon, IL-2, and IL-6. They are essential for defense, but hostile to the embryo in the excess. Then you have the Th2 anti-inflammatory cytokines. They are mainly, remember, IL-10, IL-4, and transforming growth factor beta. These promote a tolerant environment and support the process of inflammation. So with implantation, so very important, there should be a good balance between the level of the pro-inflammatory cytokines and the anti-inflammatory cytokines within the uterine environment, especially at the maternal-fetal interface. What happens in recurrent implantation failure? There's a dysregulation. What is the dysregulation? There is a Th1 dominance. An increased Th1 Th2 ratio is a hallmark of immunological recurrent implantation failure. With the result, the environment is very hostile. High alpha TNF alpha levels can indirectly impair trophoblast invasion and induce apoptosis. What is the clinical relevance of it? The clinical relevance of this Th1 Th2 imbalance is the diagnostic markers TNF alpha IL-10 ratio is used to assess the systemic immune balance. Again, the problem is the problems with respect to implantation are occurring within the uterus, and how can a peripheral diagnostic test be representative of what is happening within the uterus? That is why routinely TNF alpha IL-10 ratio is not being performed in the laboratory by the clinician. The therapeutic target in people with TNF alpha IL-10 ratio altered is to give medications like steroids and anti-TNF agents to restore this balance, but these are found met their Waterloo and they are no more used. The hostile uterus. So getting into the uterus, you find excessive Th1 cytokines create a biochemical barrier that prevents the embryo from successfully communicating with the endometrium, leading to failed attachment or early chemical loss. This is a cytokine seesaw. If you take the cytokine seesaw in normal pregnancy, you will find that the weighing is more towards the anti-inflammatory cytokines IL-4, IL-10, and transforming growth factor beta. So the normal pregnancy has a Th2 predominance, whereas if you take implantation failure, on the other hand, on the right side, you will see it is a Th1 dominant with TNF alpha, gamma interferon, IL-1, and IL-2. So the cytokine seesaw will tell you that there is an alteration of the Th1 Th2 balance more in favor of inflammatory cytokines rather than anti-inflammatory cytokines. Visualizing the shift from Th2 mediated tolerance to pro-inflammatory Th1 dominance is the hallmark of recurrent implantation failure. So what happens in healthy pregnancy with respect to the cytokines? In healthy pregnancy, it is characterized by Th2 dominance. Anti-inflammatory cytokines IL-10 and IL-4 promote maternal fetal tolerance and healthy placentation. So remember, for pregnancy, you should require a very good balance between Th1 and Th2 cytokines. Th1 cytokines are pro-inflammatory cytokines, whereas Th2 are anti-inflammatory cytokines. There should be a good proper balance between them for the process of implantation. And in the process of implantation, what is very important, it should be a Th2 dominance rather than a Th1 dominance. So coming down to the clinical marker, again, we have the TNF IL-10 ratio. It's a key diagnostic tool to assess the systemic immunological balance. But unfortunately, what happens in the periphery cannot be representative of what is happening within the uterine environment. So no wonder estimation of the cytokines in the peripheral blood is become obsolete now. HLA, the uterine HLA, and the key factor in the adaptive immune system. The HLA is like the cellular ID card or an Aadhaar card. Establishes your identity. But for the HLA system, none of us will be able to distinguish between self and non-self, and we'll be fighting there'll be a civil war going on in the human body. So HLA proteins are nothing but present on the cell surfaces that allow the immune system to distinguish between self and non-self. Maternal fetal acceptance. Critical for the mother's immune system to recognize and accept the semi-allogenic embryo system. The HLA system plays a very important role. And like gene polymorphism, we have HLA polymorphism. HLA polymorphism is responsible for the high variability ensures unique immune signatures for every individual. Greater the variability between the partners, higher is the chance for implantation. So very important is like how people have a horoscope to match before their marriage. The most important point is if in marriages, the horoscope becomes the horoscope after marriage. The uterine environment, which I shall discuss later. Key factor, the HLA2 HLA-KR interaction, the lock and key mechanism. HLA-C is expressed by fetal trophoblast and it is the key, whereas KAR receptors are present on the maternal uterine NK cells and that is the lock. The interaction determines whether the immune system supports or rejects the embryo, and this is a very important signaling point. And in addition to that, we have HLA-G proteins present on the trophoblast, where you have the fetal maternal handshake molecule expressed on trophoblast, modulates maternal fetal intolerance. Reduced expression is linked to RAF. Reduced expression of HLA-G protein on the trophoblast is linked to recurrent implantation failure. So what is the high-risk combination when you do the HLA-KR typing? KRA haplotype, mothers with this profile lack certain activating receptors. Fetal HLA-C2 combined with maternal KRAA, it significantly increases RAF risk. So the clinical impact of this high-risk combination is poor spiral artery remodeling and restricted trophoblastic invasion, resulting in recurrent implantation failure. This is a beautiful photo diagram which will demonstrate to you the interaction between the HLA and the KR, the molecular handshake. The normal one, if you come to this side, the uterine natural killer cell is there, and then you have an KRB, and then you have the HLA-C2 present on the trophoblastic cell. This interaction between KRB and HLA-C2 it causes activation of the opening of the key, and this opening of the key leads to healthy invasion, that is increased proper placentation and uteroplacental blood flow and a successful pregnancy. On the other hand, if you take the high risk condition, you have the KARAA and the C2. This is a dangerous combination. There is no activation. In fact, there is inhibition, and this inhibition leads to shallow invasion of the implantation of the embryo and increased risk of poor placentation. So, how would you define the HLA-KR interaction? It's called the molecular handshake. The mechanism: maternal UNK cells use KAR receptors to read the HLA-C molecules on the invading fetal trophoblast. The balance: a healthy handshake triggers cytokine release, vasodilator, endothelial growth factor, platelet-induced growth factor for spiral artery remodeling. The high-risk combination. I did tell you about the high-risk combination of maternal KARAA inhibitory plus fetal HLA-C2, the strong ligand, excessive inhibition of UNK cells leading to poor placentation and RAF. The medications which are being given to these people with an abnormal HIR-KR typing is granulocyte macrophage colony stimulating factors, but still they are in their infancy because there are no large-scale randomized controlled trials done in them. So we finished the cytokines, we finished the HLA-KAR interaction, and now we come to natural killer cells. Natural killer cells are members of innate immunity. They are present in the periphery, they are present within the uterus. The peripheral NK cells are the sentinels. They are cytotoxic, primarily involved in killing infected or cancer cells. The threshold elevated levels more than 18% are associated with RAF, but now they are not routinely done as investigations for RAF, the peripheral blood. Hostility, their very high activity reflects a systemic hostile immune state. They circulate in the blood but can infiltrate the residua. We're coming down to uterine natural killer cells. Uterine natural killer cells are those cells which are active at the site of implantation, and these are called the builders. In contrast to peripheral natural killer cells, uterine natural killer cells are non-cytotoxic. They are distinct from blood NK cells. They promote angiogenesis and spiral artery remodeling. They are made to make up to 70% of decidual lymphocytes in the first trimester, and they are essential for establishing a healthy maternal fetal interface. Now, one important fact is to do an endometrial biopsy and do an estimation of the uterine NK cells and see their density. But now this is also gone out of vogue because it depends upon the time of the menstrual cycle and also the pathology department. So nowadays, uterine NK cell typing is not done routinely in recurrent implantation failure. The problem in RAF is not just the number of NK cells, but the abnormal function. A phenotypic shift of UNK cells towards a more cytotoxic profile disrupts the delicate balance required for successful placentation. Then you have the T regulatory cells, Tregs. The T regulatory cells are the peacemakers, the peacekeepers. Very good people like now what Pakistan is trying to do between Iran and USA. The T regulatory cells are known for immune suppression, socialized T cells that dampen excessive or harmful immune responses, and they are responsible for maintenance of tolerance, especially essential for preventing maternal immune rejection of the embryo. Now we come down to the TREG T17 balance. What are Th17 cells? They secrete pro inflammatory cytokines. And the ratio, a healthy pregnancy requires a high Treg to T17 ratio. Now, what happens? The consequences in recurrent implantation failure, a decreased Treg to Th17 ratio leads to a loss of maternal fetal tolerance, creating a hostile inflammatory environment within the uterus that targets the embryo. So T cells are very, very important. Treg cells are very, very important for immune suppression. Now, antibodies. Now we have if antibodies are B cell mediated, they're secreted by plasma cells, with the precursors are B lymphocytes. We have the antiphospholipid antibodies. The antiphospholipid antibodies, when it comes to mechanism of thrombosis, in addition to them conferring a hypercoagulable state, they directly impair invasion and placental development of the trophoblast, and they are associated with early implantation failure and preclinical loss. Studies have shown that the high frequency of elevated antiphospholipid antibodies in people undergoing IVF, and in some they've been found to be pathogenic for recurrent implantation failure. No wonder heparin and low-dose aspirin has become the order of the day in patients with RAF and APLA. Anti-nuclear antibodies. Now, anti-nuclear antibodies is another thing which is positive in about 7 to 10% of RAF because the mechanism is mainly inflammation. Markers of systemic dysregulation or underlying disease, they cause a hostile environment in the uterine interior milieu. Clinical marker, they're often used to screen for broader immunological RAF. The important point is when you do an anti-nuclear antibody as a rheumatologist, we do it also to exclude systemic connective tissue diseases like systemic lupus and Sjogren syndrome, in which reproductive outcome is quite bad. Then you have the anti-thyroid antibodies being routinely done in RAF. Markers are anti-TPO and anti-TG antibodies. Very important here, the patients can be euthyroid, but they have anti-TPO and anti-TG antibodies, and thyroid supplementation should be given to these patients. The immunology of RAF, why does it fail? The immunological paradox. The fetus is a hemi-allograft, 50% foreign. Active tolerance is the most important fact. In normal pregnancy, the immune system supports angiogenesis and tissue remodeling. Tregs suppress rejection and promote a nurturing environment. A shift towards rejection. There's a dysregulation. The delicate balance of tolerance is disrupted. The host environment is very hostile. The key mechanisms of failure are failure of HLA-CKR signaling system, effector inactivation, increased NK cytotoxicity and Th1 dominance, deficiency in the TREG-mediated suppression, and generation of autoantibodies. Clinical insight in RIF, the maternal immune system treats the embryo as a foreign invader rather than a protected nest. Diagnostic approach, whom to test. Those people who have failed IV cycles, explained, unexplained RIF, autoimmune history. Next slide, please. Immunological workup. This is where I like to talk a few words about it. I did tell you, mentioning about estimating the peripheral natural killer cells. The peripheral cell estimation may not be representative of what is happening within the uterus. Uterine NK cells is also not being done routinely because it depends upon which phase of the menstrual cycle is being done, but people choose the mid-luteal phase. TREG Th17 ratio, assessing the balance of regulatory versus inflammatory cells. Again, it may not replicate what is happening within the uterus. Molecular markers, cytokine profiling, Th1 and Th2 ratios, namely Th and alpha and IL-10, and gamma interferon and IL-10, it's not to be done routinely. HLA typing, identifying HLA C1 and C2 alleles in both partners. It's also not done routinely. It's done in people who have had multiple pregnancy losses and in whom, and if there is a HLA mismatch, then there's a chance for giving lymphocyte immunotherapy. KAR typing, not a routine one, more of research, where the maternal KAR haplotype AAA versus B to assess interaction risk. Serological markers. All patients with recurrent implantation failure, you have to screen them for anti-nuclear antibody by indirect immunofluorescence, not by ELISA. You have to do the antiphospholipid antibodies, namely the lupus anticoagulant, the anticardiolipin antibody, and the antibody to beta-2-GP1. Thyroid antibodies, namely anti-TPO and anti-G antibodies with thyroid function test, and vitamin D levels because they are linked to immune modulation and RAF risk. Summary of investigations. This, I'll just skip this slide because I've already talked about it. Next slide. Diagnostic criteria in the India specific context. What is the problem here? Lab standardization. Assay variability. Significant differences in NK cell flow cytometry and cytokine ELISA results across labs. Reference ranges. Lack of India-specific normative data for UNK cell density. Quality control. Need for NABHL accredited centers for specialized immune testing. Cost and access. Financial burden on the couple. Then centralization. Advanced tests often require samples to be shipped to metro hubs and the delay. Clinical phenotype, we have nutritional factors, widespread vitamin D deficiency impacting immune modulation, infectious overlap, high prevalence of genital TB mimicking or triggering RIF, autoimmune burden, high incidence of thyroid autoimmunity, and SLE in the reproductive age group. This is the last few slides. Treatment paradigm with respect to APS, aspirin and heparin is the drug of choice. Patients with recurrent implantation failure due to antiphospholipid antibody syndrome had to be started at a low dose aspirin along with low molecular weight heparin. In fact, low dose aspirin and started even before embryo transfer and continued through embryo transfer till 36 weeks of pregnancy. Low molecular weight is done immediately on the day of embryo transfer. We have enoxaparin, which is a wonderful drug, and low molecular weight heparin inhibits complement activation and reduces inflammatory cytokines. It promotes trophoblast invasion and prevents apoptosis. It is essential in APL positive RAF, often used empirically in RAF also. In my practice, I definitely use low molecular weight heparin empirically in our recurrent implantation failure, and it has given rewarding results because most of the people, fertility specialists who refer patients to me, have told me that there is an improvement in the successful pregnancy group. Immunological treatments, I would not like to discuss about it because there is no standard RCT, large scale RCT trial on any of them. So we should not use these medications indiscriminately in patients with RAF. Next slide. Next slide. Do's for RAF management: perform a systematic workup, manage expectations, collaborate multidisciplinary growth, personalized treatment, and ensure lab quality. There's a new star on the horizon. This is the last slide. A wonderful drug called hydroxychloroquine, which is a drug used in rheumatology. It has become so popular in, recurrent implantation failure and antiphospholipid antibody syndrome. Now, hydroxychloroquine is an anti-aggregant, it's an antithrombotic, it is anti-inflammatory, it's an immunomodulator. It enhances Treg cell activity. It reduces the Th17 response. It improves endometrial fetal tolerance. It reduces NK cells. It inhibits activation of complement in the maternal fetal interface. It facilitates the process of implantation. So it is promising to be a wonderful drug in the management of recurrent implantation failure. Now, indications are RAF with an autoimmune background like a systemic lupus, positive ANA, anti-Rho, anti-La, undifferentiated connective tissue disease, obstetric IPS, and positive APLA test, and recurrent implantation failures more than 2. Protocol: start hydroxychloroquine 300 mg HS or 200 mg twice a day for 8 weeks prior to the embryo transfer and continue through ET till delivery. Advantage: good safety profile. Caution: retinal toxicity. Complete evaluation of the eye once in 6 months. Don'ts for RAF management: don't treat blindly. Don't ignore the male factor. Don't overlook infectious overlap and don't promise 100% success. In fact, you can turn around and ask me, why are you talking, what are you talking about hydroxychloroquine? You say don't treat blindly. Now, there is a very big study which is going on in the world about the efficacy of hydroxychloroquine in recurrent implantation failure. The results should be out in a few months, and let us see what it has to say. Next. Next. So the carry home messages are: RAF is a multifactorial puzzle. Rational therapy is the order of the day. Targeted workup is essential, and collaborative care with the obstetrician, the rheumatologist, and the hematologist working together to get a successful pregnancy will be the primary objective of management. Thank you.
Thank you, sir. Thank you, sir, for the step-wise basics and then advanced testing and everything. Personally, we have seen much of experience and we have got the benefits of using HCQ both for our recurrent pregnancy loss patients and recurrent implantation failure. So there are a few questions in the chat box. One is HLA-C2 remain constant on all embryos?
Yeah, HLA-C2 is constant on all embryos.
Sir, how to continue aspirin and low molecular weight heparin in a setting of recurrent implantation failure or recurrent pregnancy loss? When the woman comes back with a spotting or bleeding period, when there's a threatened miscarriage, how long to stop and when to restart the aspirin and heparin?
We stop the aspirin and heparin at least for a week. And once the bleeding stops, we introduce the heparin. And then after a week, we introduce the aspirin again. The other important thing which I would like to tell you is when people have failed to 40 milligrams of enoxaparin, you can change to 60 milligrams of enoxaparin. I have had patients in whom I have given 40 milligram of enoxaparin twice a day and they have come out well.
So that's true.
And the dosage of hydroxychloroquine is 5 milligram per kg body weight. The tablet is available as a 200 milligram tablet. And it's very cheap. It's only about 2 rupees. It is the poor man's heparin.
Is there any cardiac contraindication or monitoring needed for the HCQ, so ECG or anything?
Not necessary at all, because it is supposed to shorten the QTC interval, but it is not seen. It's a very, very uncommon problem. You need not have an ECG taken before you start a patient on hydroxychloroquine. And even a cardiac patient can have hydroxychloroquine.
Yes, sir. Thank you very much, sir. Thank you for a very detailed basics as well as going up to the practical take home points. Thank you for staying with us, sir. Thank you very much. Thank you, sir.
Is it all right?
The next speaker we have is Dr. Naina Patel ma'am to highlight us on the regenerative medicine area. Naina Patel ma'am is the medical director of Akansha Hospital in Anand City. She is a pioneer in the field of IVF and surrogacy. So far, 1,737 surrogate babies were born at her center. She is also an author of Advances in Assisted Reproductive Technologies. Her research interests for regenerative medicine, gut microbiome, ovarian and endometrial biomarkers. So over to you, ma'am. Welcome, ma'am.
Thank you. And thank you for having me over here. After this wonderful talk from Dr. Ramakrishnan, now I will start another talk, which is not still very acceptable, universally acceptable, but yes, which is definitely playing a role in infertility, and that is the regenerative medicine. I pay my tribute to late Dr. Shankar Narayan from Trichy, who helped me in this field when they were doing it for dentistry and for other indications, osteoarthritis. I was the one who accepted it, and we started for the infertility treatment. Regenerative medicine definitely holds a potential to aid the infertility treatment. As of now, the treatments available are like IUI, IVF, IVF with donor eggs, IVF with donor sperms, or IVF with donor egg sperms both, and lastly, surrogacy. And most of the patients where we are treating infertility, first thing we look at is the gametes, the functional gametes. And the couples also want to use their own functional gametes, and they don't want to opt for donor eggs, donor sperms, or they want to try with their own uterus and not go for the surrogacy or third-party reproduction. So the next question that comes is it the time to rejuvenate ovaries and endometrium? If yes, when, how, and what is the potential and the outcome? So definitely regenerative medicine holds this potential to aid the infertility treatment. If we look at regeneration, it is a broad term wherein we try to imply that the process in humans whereby lost specialized tissue is replaced by proliferation of undamaged specialized cells. So there we have the platelet-rich plasma. Now we have the access to the exosomes also, the stem cells, and these are being used to regenerate. So what is platelet-rich plasma? I think all of us are now quite convinced about it, and we are using it for the regenerative part, which started from dermats and orthopedic surgeon for osteoarthritis. We know that the process of preparing is very good. A procedure will get a good name or bad name, but when it is not done properly and then you give a bad name is not correct. So preparing the autologous PRP preparation, though it appears very simple, it has to be very meticulous, and there are various things that you need to check once you complete that procedure. You need to do a pre-check also, post-check also, that what is the platelet count, what is there in the droplet after that, when to activate it, because these platelet granules will have the growth factors which will be released within 15 minutes of activation. And if within that 15 minutes we are not able to inject it in the site where we want, the outcome will not be good. Again, if it is prepared and it's lying down for quite some time before you use it, it will not give good result. So all these factors are very important. And how does it act? By an anabolic effect, which is releasing of the growth factors, by a scaffolding effect through fibrinogen, and an anti-inflammatory effect through the inflammatory mediators. And this particular paper is very good because it will tell you that what is the volume you need. You may need 30 ml first, 40 ml first. What is the number of times the platelets go up, 4 times, 5 times. Then what is the leukocytes that are increased? What is the dosage to be introduced in which part? And finally, what is the relative composition? So activated, non-activated, usage within activated is very, very important. Now we look at the stem cells, which is again revolutionizing the healthcare treatment and is definitely making a difference for many treatment, many diseases. Now comes the role of stem cells in infertility. Why stem cells? Because they have this remarkable characteristic of multidirectional differentiation, angiogenesis, immune regulation, and paracrine stimulation. That is what we want when we want to regenerate either the ovaries or we want to regenerate the endometrium or the testicular tissue. What happens when you put the stem cells in the tissue? Because either you give it IV, but when you give intravenous, at least 70% will get trapped in the lungs. And that's why it was widely used during the COVID. But that will be not useful to us because it does not reach the target organs. So you can put it directly into the target organs like the ovary, or you can put it in the blood vessels and that will travel to the niche either in the ovary, but it's very difficult to put it in the ovarian artery. Yes, uterine artery can put it to go to the endometrium because the ovarian artery is perpendicular to the aorta and it becomes very risky for going through that route. Once you put the stem cells, immediately through the chemokine release, it will get attracted to the injured tissue and start differentiating into the cell where you have injected. Right? So mainly granulosa cells in the ovarian tissue, or it will ameliorate the damaged microenvironment and start secreting anti-inflammatory factors. And again, what we heard about the Treg cells, which are very good, which are the anti-inflammatory, should be there, which will lead to suppression of the immune system. Now, there are various types of stem cells, but we are talking about the multipotent adult stem cells, mainly the mesenchymal stem cells, which have a limited range of differentiation. It cannot differentiate and go on differentiating for a long time where we have the risk of tumors or cancerous cells. Here it has limited differentiation only. And the bone marrow derived stem cells are majorly that we use, but adipose tissue stem cells, menstrual blood stem cells, human breast milk stem cells are also there, dental pulp stem cells are also there. The advantages of using mesenchymal stem cells are that there is no ethical concern because we are not utilizing an embryo. It is Autologous, same. So there is limited immunomodulatory function, low immunogenicity, and chemotaxis. So this is very, very important. When we decide to use the stem cells, pre-procedure workup is there, where we commence with injection of ceftriaxone IV, 2 to 4 liters of oxygen for 30 minutes, give a vitamin C injection and injection glutathione. Basically, antioxidant environment is created. And once the patient has taken it, we also take the blood for PRP, because whenever you culture this mesenchymal separated stem cells for at least 10, 15 or half an hour, 1 hour on the platelet-rich plasma, the potency of the stem cells increase. So that also is taken. And after that, when we take the patient into the operation theater, and either from the anterior iliac, mostly now we do anterior iliac or the posterior iliac spine, with a Luer-Lock syringe, you extract about 80 ml of the stem cell, the bone marrow cell concentrate. Then that is sent to the stem cell lab for separation and for creation of the mesenchymal cells, which are separated. We do it under anesthesia because this needle for aspiration is quite thick. After that, you can do a manual method or you can do a machine processing, where the stem cell separators are there, the processing units are there, which will separate it. Then these cells, once they are separated, a drop of it is stored with you forever as per the guidelines by the stem cell, for the stem cell culturing. You cannot keep it or passage it because that is not allowed in India. You have to check the growth, keep it there for 24 hours and see the infectious disease profile also. Though we instill it immediately, we don't have the time to do this flow cytometry, but yes, that is an ideal thing. But we have to inject it immediately, so we just count the cells, that how many mesenchymal cells are there, and 1 million per kilogram body weight is the ideal dosage. So how it helps in the infertility treatment? In female, in the ovary and endometrium, and male when there is oligoasthenozoospermia. Ovarian rejuvenation is primary ovarian insufficiency or a diminished ovarian reserve due to age, but we have to rule out any genetic condition in POI. Fertilization failure, that is one where we don't see any other reason why it failed. Recurrent miscarriages, where everything is ruled out, but there is a low AMH in a young patient also. There is a low success rate of fertility treatment, and PCOS and endometriosis are the newer indication. So what happens is, this rejuvenation will restore women's fertility, also alleviate some side effects associated with the low estrogen. So it's also helpful in the menopausal women. But you rule out the karyotype. It should be normal karyotype. There should not be any hypothalamic cause. Autoimmune disease, we can also counsel that it will be very short-lived, but yes, you can still try an autoimmune disease. Other major malignancy, hepatitis, blood count, the platelet count, everything should be seen. And any platelet count less than 1.5, that patient is not a good candidate for PRP also and for the stem cell also. Methods for injection in the ovary is either PRP stem cells by laparoscopic guidance or under the ultrasound guided transvaginally. All these years we thought that there is a fixed primordial follicle pools. We were taught that. But now there is a successful delivery of isolation and establishment of the ovarian stem cells, and that's why the regenerative therapy has brought more hope than ever. We know that folliculogenesis is a very important part of ovarian function, as it provides oocytes for reproduction. And we can see that the ovarian cortex is the presumed site for the ovarian location of the stem cells, which are dormant, which will never get activated and which will just pass on with atresia at the menopause. So whenever we are treating a disease or any organ with stem cell treatment, there has to be a role of a stem cell niche. The ovarian stem cell nest is one of the major component of the ovarian stem cell niche. And the stem cell nest is composed of granulosa cell, vascular endothelial cells, immunological relevant cells, and molecule, which surrounds the ovarian reproductive stem cells and regulate their functions. So this is the typical picture. The relevance of the niche is important because it is a key parameter that will promote an adequate follicle development to restore the ovarian function. So, regeneration of this niche using stem cells is to promote the development of remaining follicles within the ovary, which will undergo atresia and remain dormant forever. Mesenchymal stem cells have different adult tissues which have proliferated, self-renewation, and differentiation to different lineages properties. Again, the mechanism of action which I discussed, immunomodulatory, antifibrotic, regulation of the granulosa cell survival, which is very, very important, angiogenesis by formation of ovarian blood vessels, reducing the oxidative stress, also immunomodulatory and anti-inflammatory effect starts with the homing in of the stem cells. Most important, I consider, is the reduction of apoptosis and atresia in granulosa cell, promotion of cell proliferation, and regulation of pro-apoptotic proteins. So the stem cells can increase marginally the primordial follicle pool, improve the function. This is the transvaginal guided. So what we do whenever we are doing a platelet-rich plasma or we are doing platelet-rich plasma along with the mesenchymal stem cells, we have everything prepared. It is planned well in advance, what day of the cycle. If the ovaries are very small and transvaginally we are doing, we'll try to see in the mid-cycle, also try to give an ovulation-inducing agent so there is a follicle. You can aspirate it and surrounding that you can protect. But if the ovaries are adherent, not accessible properly vaginally, or you have to go through the uterus, it is better to subject this patient to laparoscopy. Once this is done, once the patient is taken into the operation theater, we do it always under a short general anesthesia. And that is the time we ask our stem cell person to activate the platelet-rich plasma. And then we measure it exactly. Normally, it is 2 ml in each ovary. And about 10 lakhs of platelet cells should be there activated. And once we are inside, we just go into the cortex and drop by drop, we put it, say 0.4 ml, and then count up to 30 to 60, that is almost a minute, and allow it to get dispersed and absorbed. Then from the same point, you go into the other area and put it. Try to avoid the follicle itself. The surrounding area is the best. We say cortex, but many a times the ovary is so small that it goes into little stroma and cortex both. But try, if the ovarian volume is good, try to inject it in the cortex only. So 2 ml on one side and 2 ml on the other side is injected. This is the transvaginal. If we do it laparoscopically, like supposing we have to do it for a patient who is undergoing a myomectomy or any other surgery, tubal patency, anything. So we still prefer a laparoscopy is the best way to do. Transvaginal is still blinded. But if a patient already has a laparoscopy done and who just doesn't want to get subjected to laparoscopy again, and the ovaries are accessible, we do it transvaginally also. This is the recent technique that we have started. You can see here some of the drops would try to come back. But here what we do is hilar and anti-hilar. Only 2 areas we put 2 punctures and very slowly we inject till the cortex gets blanched. So what happens? The retention is good. The dispersion is good and the absorption is good with minimal spillage. So this is the technique. The second one that we do now is what we are doing when we do it laparoscopically. And there are a number of publications of PRP as well as of the stem cells where they have said that it has a reproductive potential in patients who are poor responders. Especially Sonia Harris has a good study about it, and from many other using even human amnion-derived mesenchymal cells. So this was our patient with 41 years of age, 0.54. We did PRP and then we did our IVF, D3 embryo, successful healthy pregnancy. This is a patient 0.04 at 20. So total POF, and referred to us by the endocrinologist for a donor egg cycle. But they did not want a donor egg. So simple was that we did the ovarian rejuvenation, TVS get it, because we were also not confident that this patient will ever get an outcome. And we did it, her AMH from 0.04 went to 0.09. So normally what we do is every 3 months we try to see if they can go for an FSH test, and then because FSH is likely to come down first, and EMH rise will be very marginal and slow and expensive also. So FSH is day 2 what we try. She conceived naturally. She was not having menstrual cycle for 6 months, 8 months, very irregular. From there she went to 2.5 months, and then finally she conceived naturally and delivered a baby. This was a female, 34 years, 2 IVF failed in UK, both the time 2 PNRS. Male factor was totally normal, though her AMH was 1.56. She decided she had heard about us doing this and she called us. She came here with a laparohysteroscopy and ovarian rejuvenation with PRP, naturally conceived. Again, a 25 years old male and 23 years. This is very interesting that the husband had testicular cancer, so we preserved the semen. Thinking that female is 23 years, we will start testing after 1 year. Husband had come with the family to freeze the sample. 4 samples were preserved. So when they came after completion of the treatment to start the IVF, the wife turned out to be a premature ovarian insufficiency patient with 0.42. Because she was young, we did first cycle, 6 oocytes, only day 3 embryos were formed and negative outcome. So we suggested intra-ovarian PRP because now we had only 3 vials of his semen with us. And we repeated the cycle after 2 months and 3 months, and we found that there were a 4 AA grade blastocyst, and she has already now delivered, I think. So this was our publication of Promising Future of PRP in the Fertility and Reproduction, the Aspire Journal, and in-house experience in 2023, where we just gave the data of the 45 patients with 27 positive, where they had natural as well as IUI as well as IVF pregnancy also. So it concluded that ovarian rejuvenation through autologous PRP infusion shows promise in restoring reproductive function, enabling conception without using the donor eggs. But further studies are required. Now, this particular female we did with the stem cells because we had started. She had 0.09 AMH with 14.4 FSH. And we did the stem cell therapy with ovarian rejuvenation simultaneously. And very first IUI she conceived. Another patient of 33 years, 0.49 AMH, and she was HPV positive, 16. We did in December 22 laparohysteroscopy, both bone marrow derived stem cell rejuvenation. In April 24, this is 23, and 24 she comes again in 3 months, and she conceived in the first IVF. This patient had a very good AMH 2.8, 1 miscarriage, 3 IUI failed. But suddenly during COVID, her AMH fell to just 0.25. So we tried 2 IVF cycles negative. Then we did the bone marrow rejuvenation duostem, and she delivered a healthy boy with frozen embryos. And 39 years old female with 0.862, 3 IVF, 11 IUI failed. We did this procedure of laparohystro with bone marrow stem cell rejuvenation. In second IVF, she got a positive result and delivered a healthy baby. Is rejuvenating ovary helping people who have unexplained RPL with low AMH? Yes, this is our experience, and we are quite happy to say that when you don't find any reason for RPL, it's just the low AMH and there is repeated miscarriage, ovarian rejuvenation can definitely be offered. This patient, 2 IVF, 2 failed, but 2 miscarriages, naturally conceived with 0.32 advised donor egg. We did this rejuvenation with bone marrow and she conceived naturally and delivered. And 46 years old, 0.88, though not low, but at 46 years, majority of the eggs are going to be abnormal and she had history of 4 miscarriages. So here she comes, we advise donor egg like they had advised in the USA. In USA, when IVF failed, we suggested we do laparoscopy with ovarian tissue activation and rejuvenation and a lead therapy. She conceived and delivered a baby boy. Now there is an unpublished data which we have and the number has increased where we have taken RPL patients with no other cause for miscarriage with except for low AMH, and out of 51 we have 27 positive with 24 delivered and 3 miscarriages. Endometriosis is again an inflammatory condition, that is release of cytokines which affect the infertility. And recent experimental evidence in both animal and human models, I have not put up that paper, as late as 25 and 26 January, we have got these publications where they have shown that there is promising results of stem cell based therapy for the restoration of fertility in patients with endometriosis. We know it affects 10% of the patients, and mesenchymal cell therapy has theoretical risk of disease progression. That is what they asked me. But it has also been shown that because of the EVs, the potential by targeting angiogenesis and inflammation, this is a preclinical data, so it shows the hope of mesenchymal stem cell in endometriosis. I cannot go into the detail of all this, but this publication is very good where they have given the detailing of use of stem cells for endometriosis. This was of a patient. She had grade 3-4 endometriosis, 30 years of age, and 0.97 is the AMH. So once we cleaned up the full endometriosis, after that in the cortex, we injected the bone marrow derived stem cell. There are people who are worried that PRP can increase the progression of the stem cells, but no. Basically, it is anti-inflammatory, anti-fibrotic. So it will reduce the fibrosis also after the surgery, and at the same time, whatever remaining pool of the primordial follicle is there can get rejuvenated with the stem cells and the PRP that you inject. But the completion of the procedure should be there. So this, after completion in the cortex, we are injecting the bone marrow derived stem cells and the platelet rich plasma. After that, we first did our IVF with 1 egg retrieval and embryo freezing. The second cycle we got 2 eggs and 2 day 3 embryos. We transferred that and successful delivery in December 2023. Again, another case, 37 years, 2 miscarriages, AMH 0.15 and chronic endometriosis. She didn't want a laparoscopy surgery. She was worried about the reserve. So we did hysteroscopy, BMDC, ovarian rejuvenation, TVS, and subendo PRP. She conceived naturally and delivered. PCOS is again one condition where there is a highly inflammatory condition, and human mesenchymal cells can suppress the Th1 response which is there, which influences the internal inflammation in PCOS. So the ovarian function may recover after the cessation of autoimmune reaction and regression of concurrent endocrine disease. So it is said that human mesenchymal cells in PCOS patients will help in reducing the internal inflammatory environment. And the same publication of 2025 Journal of Ovarian Research has shown that how the umbilical cord mesenchymal stem cells can help in resolving the polycystic ovarian syndrome, or PMOS, what we call it now. Recent trends in polycystic ovarian syndrome, a review article with stem cell therapy, and they found that stem cell shows potential in PCOS management, hormone balance, follicle development, antioxidant and anti-apoptotic effect, and may offer alternatives to conventional treatments for metabolic complications. We have done number of cases now. We are just finding out the analysis, and we do PRP and stem cells for PCO patients who are really the type A, which were, or B. Now, in vitro activation is also a regenerative type of medicine where we activate the primordial follicles that leave their quiescent stage. So, stem cells and PRP could be targeting this, but here we are targeting the primordial follicles to use it, and the disruptions of the hyposignaling promotes the follicular genesis. The whole fragmentation of this. So, this is the technique. We just remove the cortex. This has been done by Claus Anderson in Denmark, who is not approving anymore. But Professor Kawamura from Japan is still approving and is undergoing study going on, where we take out the cortex and the small bit of cortex is sent into the lab, where it is cut into very, very thin slices, say 60, 80, 120 pieces also. And once that is done, it is put into a vial. From there, it is transferred into the infant feeding tube. And now we have a special equipment for that. And this is how the small pieces will be transferred into the ovary bag, and then the ovary can be sutured. So while we have disrupted mechanically this, the follicles then tends to start growing. Normally what we do is we give the estradiol prior to this and the progesterone. Last day of it, we do the surgery, then wait for the menstrual cycle, and then we start the stimulation immediately, because these are the secondary follicles also, and the primordial follicles also getting activated. So these are the publications which are there, and this is Professor Kawamura who had come to our clinic, and we started this. This was the first publication of India where the drug-free in vitro activation of POI, which was published in Journal of Human Reproductive Sciences. This patient 34, 0.22, very low AFC, and we had nobody tried the ovarian tissue activation. We tried on the one side, we did not do on the other, because it was the first case. We wanted to be very sure that there is no harm to the ovary. Then we did our IVF cycle. We got 3 good quality day 3 embryos were transferred, and that was from the right ovary only. Left ovary embryos were not used, but she had a miscarriage. After that, she was waiting and she conceived naturally. And that time the corpus luteum was on the right side of the ovary. Thin endometrium is again one problem which is giving a lot of frustration, because a good endometrium is required for implantation and pregnancy maintenance. Anything less than 7, now they say volume, good endometrial texture, yes, but even the thickness. So all this improving the thickness of the endometrium, blood flow and receptivity. So this thin endometrium will reduce implantation, obstetric complications will be there, and adverse perinatal outcome. We have the functional and the basal layer. Functional layer is shed every month, but the basalis layer will then regenerate into the functional layer. If the embryo is implanted in the functional layer, where the thickness of the functional layer is good, the implantation is good. But when it becomes thin, the endometrium, the basal layer with very high spiral artery oxygenated blood flow will be detrimental to the implantation of the endometrium. And various modality of treatments are tried, but regenerative medicine is now accepted by many. Umbilical cord, but we again use the autologous bone marrow derived stem cells. It helps in endometrial regeneration by proliferation and reducing the fibrosis. Endometrial stem cells are located in the basal layer, and they have the potential for high proliferation, cell renewal, and multilineage differentiation. if you see the basal spiral arterioles, in the basal layer, the uterine artery spiral arterioles are there. Surrounding that spiral arteriole, you can see on the right-hand side are the stem cell niches. So if we go right up to the spiral arterioles and inject that stem cells, immediately they will come out of it and get into the stem cell niches, which will attract them because the stem cell niches are already damaged, releasing cytokines. Stem cell niches are very dynamic, complex, and heterotypic changing structures. And in the treatment of intrauterine adhesions, what we want is we want to reduce the endometrial fibrosis, we want to repair the damaged endometrium and improve the receptivity, and that is what exactly the stem cell therapy will do. The mechanism of stem cells to repair endometrial damages by transdifferentiation into epithelial, endometrial, vascular endothelial, and stromal cells. Also through parakine effect and the immunomodulation. So mainly there is cytokine induction with growth factor production, natural killer cell activity reduction. The bad Th17 and Th1 cells reduce and the good Treg and Th2 increase. So you do it simple intrauterine installation where we prefer the PRP, especially when the receptivity is not good. When the thickness is not good, maybe you do it 2 or 3 times. When the receptivity is not good, you can do it 2 days prior to the IUI, prior to the embryo implantation. And also in patients of endometrial, where you get the endometritis patient with repeated fluid in the endometrial cavity, keep doing this. Take the fluid for culture, do a PRP, do after 2 days, do after 2 days again, and you will be surprised that the intrauterine fluid goes down to just a drop or nil, and the patients get positive results. Another method is this is 2 to 8 days, like an intrauterine. Very slowly you inject about 0.2, 0.2, 0.2, maybe 0.6 or 0.7, maybe the maximum, and do it under ultrasound guidance also. During hysteroscopy, what we do, we clean up all the adhesions. And then with the egg retrieval needle only, we inject it into the 4 walls. And what basically we do is that we do it under ultrasound guidance. We go to the anterior wall. We deflate the cavity totally. The total fluid will come out and then we inject it and wait for some time. Again, we'll fill up the cavity after 1 minute and go to the other wall. So totally 0.8 or 0.7 in all the 4 walls are injected. So about 2.8 ml we take it, but very slowly ultrasound guided procedure is being done. And you deflate, inflate so that there is no leakage of the PRP or the stem cells that you are injecting. And these are number of publications regarding the same. But this is the process where we master this art and we do it after we followed the Carlos Simon study. Here what happens that we need to target the endometrial stem cell niche, which is located at the endothelium of the spiral arterioles in the basal layer. So patients of Asherman syndrome and endometrial atrophy will definitely benefit from this. The reason could be any. And they have used only CD133, but we used all the CD cells which are available in the bone marrow derived mesenchymal stem cells. Again, the same effect is seen, which is the transdifferentiation, activation, immunomodulation, angiogenesis, antifibrosis, anti-apoptosis. So we got the approval from the ethical committee. We have the Department of Health Research certificate, DHRS. We have the good practice and the CDSCO certificate to use the mesenchymal cells for reproductive medicine. This is our setup. And once the patient comes, all the consents are taken. The 1 hour of oxygenation is done. Then the stem cells are taken in the same anesthesia. We do the hysteroscopy. So once the hysteroscopy is being done in the patient, we try to inject the PRP at that time. And then the stem cells by then get ready. Once it is ready, we go to the cath lab. Through the femoral artery, we go to the opposite uterine artery. And then from the opposite uterine artery, once it is negotiated, we go to the, we pass the microangiocatheters, which will go to the spiral arterioles. You can see this procedure being done here. And then as a rule, one of us is present. That time the patient does not need anesthesia, only a local anesthesia around the femoral artery. We have now replaced it with a much simpler technology, but we are waiting for the result. Now this is gone through the opposite uterine, and you can see once it reaches the uterine artery, we negotiate the uterine artery. And after that is done, at least we inject 1 ml to 1.5 ml in both, with at least 15 million of the 15 million of the stem cells. Here you can see we have negotiated the uterine artery and we have put the stem cells, and after some time we inject the fluorescent dye so that we know that it goes through the spiral arterioles. That means our stem cells have gone through the spiral arterioles and they are attracted by the stem cell niche endometrial thing. So this is the technique, and this was the publication of a birth of a healthy infant after bone marrow derived cell therapy, the SERM. And there we showed that this patient, 26 years, because history of tuberculosis is very important in our country, that causes the thin endometrium. She was advised surrogacy. We suggested her this therapy. She went for this therapy. And then by May, her lining was very good. And that is the time we transferred, and she delivered a healthy baby. After that, there was a patient from Bangalore where she had her embryos frozen, but lining was the issue for almost a year. We did the same procedure and she delivered the two healthy babies because the endometrium could reach 7 mm. And then this report of severe fibrosis adhesions, only often on brownish discharge. DNA was done twice, and that was the reason, the traumatic. We did the same procedure. These are the patients who have 4, 5 failed hysteroscopy, subendo, PRP, everything done, but not getting a good thickness of the endometrium. And these are the patients where we suggest this. So we published a 12 patients pilot study in the Journal of Regenerative Medicine. And there we found that the outcome was very good, because out of this 10, 6 had good results. 1 opted for surrogacy. And this is for the first time, to the best of our knowledge, in the world, where 10 patients, because 2 did not respond at all, where BMDC were used to isolate and instill into the uterine artery through interventional radiology. So now 55 cases where we had 24 positive, 17 delivered, 1 preterm, but 2 unfortunately had obstetric hysterectomy. The baby and mothers both are fine, because there is a risk of placenta accreta. Then we had 3 miscarriages, but 1 patient again pregnant. And the procedural complication was, when we were going through the femoral artery to the opposite hypogastric artery, there was suddenly the disruption of the artery, but immediately the vascular surgeon was called and stenting was done. Patient is fine, and now patient is again coming after 3 months for the transfer. These are exosomes which we have started using, not from the stem cells but from the PRP. Future direction is definitely we should know the dose route of the exosomes, exosome hydrogel systems, pure hydrogels, and the scaffolding systems, because scaffolding for the ovary is the thing that is going to come up, where we can load the stem cells for slow release for a longer and better action. To conclude, I will say that patients want to use their own egg. So if it's a patient of POI, DOR, PCOS, endometriosis, or unexplained RPL, or fertilization failure due to low oocyte quality, rather than suggesting a donor egg, it is better to opt for the regenerative therapy, which suits them the best. The stem cell therapy definitely targets the endometrial niche to improve the endometrial thickness and the endometrial receptivity, though further research and large trials are required, and molecular basis of the treatments needs to be evaluated and revealed. But most important in regenerative medicine is proper case selection, proper technology, and only then offer to your patient to get the best result and to give them a hope. Otherwise, you are giving a bad name to this good procedure. Thank you.
Thank you, ma'am. Thank you for the detailed step-by-step procedure, the various methods and everything. Ma'am, we have a few questions posted in the chat box. They have asked you to elucidate on the GCSF-induced mobilization before stem cells.
No, look, that is when you are using the peripheral blood. 3 days prior, you start giving the GCSF, and that take about 300 ml of the blood, like a good quantity you have to take. This GCSF is only to mobilize it while we are taking it directly from the bone marrow. So that is only one shot prior to it. But if you are taking peripheral blood and using apheresis technique to do it, then you need to give it 3 days prior.
Any age limit for using this PRP and stem cells to maximize the results?
For the ovaries, we have a limit of maximum 40. Beyond that, we'll say that it's like you already have an advanced stage where the chromosomal abnormality will be high. But still, if you want, we go ahead and up to 45. That was the rare case we did on 46 because the patient insisted with proper consent and counseling and documentation. For endometrium, I think we can go even up to 48, 49 because 50 is the limit where we cannot use it.
Which days of cycle ovarian PRP is preferred? How many times it can be repeated and interval between the use?
So if they are talking about ovarian rejuvenation, we can do it in the mid-cycle, which is the best because we would know that there is a growing follicle and the volume will be good. But supposing the patient has already a good volume and you can visualize it transvaginally, any time of the cycle you can take it. Avoid the menstrual period, but other than that, any time can be done.
Okay. When should we do OCR following ovarian PRP? Immediately can we go to the next cycle or should we wait?
Look, ideally they say that we are talking about the primordial and the secondary follicles both, which can be helped by it, mainly primordial. So you wait for 3 months, that is the 90 days. But then you have to weigh the advantages, disadvantages. If the patient is already 41, we don't want her to wait for 3 months. We can start immediately the next month also. And
how long does this effect of PRP
yeah, we
on
have
the
seen up
stem
to
cells?
18 months also we have seen. And no need to repeat it if your first procedure is very well done. I don't think you need to repeat it.
Yes, ma'am.
Only in rare cases, we go ahead and do it again. But on an average, ours is only one time. There are publications where they have shown 3 times every month because they say that is the best way to improve the rejuvenation of the secondary follicles. But we do not do that every month, no.
There are two questions. Basically, what are the government clearances to start the stem cell therapy in an ART clinic, or what are the certifications needed before starting stem cells?
So look, stem cells are actually what? When you take out the mesenchymal cells, the autologous separated bone marrow cells, and then you passage it and culture it. So when you culture it, maybe on PRP or anything, and then you wait for 7 days. Once the flask is full, you passage it. 3, 4 passages, after that they become the stem cells. And 4 to 7 passages is the ideal time to use the stem cells. That we are not doing. So the terminology itself has an error. We should be ideally using the term bone marrow derived cell concentrate because all we are doing it is separating the mesenchymal cells, as passage cells are not allowed. In India, as of now, stem cells are not allowed. And there was one circular where you cannot, but autologous cell separated mesenchymal cells can be used.
Thank you for being patient and clearing all the doubts, ma'am. Thank you very much for staying with us.
Thank you so much.
Thank you, ma'am. Now we move on to the much awaited.
Good evening, Dr. Naina. Asha Rao here. It was
Hi,
a wonderful
Akasha.
lecture.
Thank you,
I
Dr.
think
Asha. Always
we
nice
had
meeting
thoroughly
you.
enjoyed. It was a mind-boggling talk. Thank you so much
Thank
for
you.
clearing so many points.
Dr. Naina, it was so nice to see your experience in the stem cell. Very good lecture, madam.
Thank you, Dr. Ramani Devi. Thank you so much.
Thank
Do
you,
you
ma'am.
have, hi, Dr. Naina, this is Dr. Vani here. Do you
Yeah.
have special needles made for this ovarian PRP or stem cells?
No, we use the
Oocyte
needle only, the same needle.
So
We don't
it,
have special
it
needle.
leaks most of the time. So
No. You have to inject it very slowly. When you are doing laparoscopically, what we prefer a spinal needle is also good. You lift the ovary if it is mobile, bring it just below the abdominal cavity, and through the spinal needle, drop by drop, you inject. But when you are doing, we showed the second technique. First, we were also going very fast. Now we go drop by drop till there is a blanching of the ovarian cortex. So the absorption is very good. And transvaginally, you cannot make out how much is leaking, but laparoscopically, you can precisely make out that what is the amount that is being leaked. So we don't have any special, only spinal needle we can use if the ovary is free. If the ovary is adherent, then there is no point doing that technique.
thank you. Wonderful
Nice
lecture.
meeting you, Vani. Nice meeting you.
Yeah, thanks.
Thank you, ma'am. Moving on, we have the much awaited panel discussion. As we already saw a part of it, we have only stalwarts sharing the screen with us today. We have our moderator, Dr. Vani Pujari ma'am. She is the director of Akshaya Fertility Center and Women's Care. She is the founder president of Scott and treasurer of Tapiza Repressing. And we have Asha Rao ma'am. Ma'am is the director of Rao Hospital and Premature and medicine and endocrinology. She's also the ICOG governing council member. Next, we have Dr. Ramani Devi ma'am. Ma'am is the managing director of Ramakrishna Medical Center in Janani.
Ma'am, we were not able to hear you.
We have Professor Dr. P.G. Anandi ma'am. She's a fertility consultant in Anne Hospital and Sri Teshri Baby Center in Madurai. She's a patron member of the PCOS Society of India. And we have Dr. Divya Shri P.S. ma'am from Bangalore. She's the medical director at Genia Fertility Center, Bangalore. And she's the state board for ART and surrogacy, health and family welfare government of Karnataka. She's the secretary of IFS Karnataka chapter. Over to you all, ma'am. And we have an embryologist joining, Dr. Yamini Ashokan, ma'am. She's our very own embryologist in Triple M, and she is the lab coordinator and mentor for FMB and Triple M Fellowship in Reproductive Medicine. Please take over.
Thank you, Dr. Kundavi and Dr. Jinavia, for giving me this opportunity. And good evening, everyone. As you can see, there are so many experienced people. So my job will be simple. Can you see? Yes. Okay. So we'll try to have as practical talk as possible, practical discussion as possible, because we had three good solid lectures and really covered so much of reproductive medicine and sir has covered so much of immunology, which is made my job very, very easier. Madams, you can just take it. When do we call it RIF? We will try to see in our we have been evolving in calling RIF. When do we call RIF, and what are all the investigations we do? I'm sure with your experience, vast experience over so many years, the way we approach it and the number of investigations we do and the focus has been shifting every 5 years at least. The focus is shifting. The current focus, obviously, like everyone knows, that it is mostly in immunology, and we are immunology and inflammation, so we are in between those two. So just to have a basic, so what do you think, Ramni ma'am or Asha ma'am? Or
Asha madam, you start the ball rolling.
Okay, thank
in
you.
your practice, what do you consider? When do you consider it is RIF?
Yeah. Recurrent implantation failure. I think we have been discussing this topic for quite a few years now. Initially, we said transfer of good quality embryos in multiple transfers. If it failed, we can call it as a recurrent implantation failure. And 2014, Kuglan et al. Said that if it is more than transfer of failure of clinical pregnancy to happen after a transfer of more than 4 good quality embryos in more than 3 cycles. But today we know that we cannot strictly adhere to these numbers. So there has been a lot of discussion, talk, and the ESHRE good practice recommendations. We say that it is not exactly a number, but it's a clinical scenario where the implantation of good quality embryos in sufficient number of trials has failed to produce a pregnancy, and there is a particular threshold for a given age and depending also the quality of the clinic. So to be practical, we can say more than 3 good quality embryos or 2 blastocyst transfers in 2 to 3 embryo transfers. This will be a practical definition. Has failed to produce a pregnancy, which can be a biochemical pregnancy. Earlier we said a gestational sac, but today the definition has gone to biochemical pregnancy.
Madam, I think even after 2 failures, we should start investigating. We need not go for the 3. That's my idea.
So
we are sure that we have transferred good quality blast for at least 2 cycles, and if we are not getting a pregnancy, I think we need to evaluate.
So do you consider euploid blasts or just blasts in your routine practice before you call it failure?
I think I don't go for this PGT, but good quality blast. Anything that's good, A or AA or AB or anything beyond this BB. Good quality blast.
Yeah, I think your question was very pertinent, Vani, because till last year we would say good blastocysts, good quality blasts. But this year that we started doing the embryo biopsy, we are talking more in terms of euploid blast because it makes a lot of difference.
Yes, the current definition is you expect that this embryo should have implanted in this particular person, and if it doesn't happen, then you start raising questions, and that is where I think the current means it is going. So in practice, you guys told us that so two transfers, 2 good quality, 2 attempts of transfer with good quality blasts. If she doesn't conceive, then we are looking at investigations. Okay,
because still there are lots of centers which are not even doing blastocyst, They are still doing cleavage cell. And I saw somebody quite senior and famous from Bombay transferring into a woman. This was 2 years back. 4 cells, 6 cells, 3 cell. He transferred 4 embryos like this. Instead of going in for a blastocyst, they have transferred multiple embryos. I think this sort of practice has to change, and we should improve the quality of the lab. The quality of the lab also matters.
Yes, quality of the lab definitely matters. So we have a couple where two attempts of good quality blast transfers have failed. So what do we start looking at? What is that we go through? What are the investigations we'll look at to start with?
Who are the other people who have joined?
I can only see both of you, so I'm
Divyashri is a.
Divyashri is not there. I didn't see her.
Anandi is there.
Yeah,
Anandi. Dr. Anandi, yeah, please.
Anandi.
If Anandi is there, we'll ask Anandi to take this question. Otherwise, we'll be.
Dr. Anandi, you are muted.
Ma'am, now it's audible, ma'am?
Yes,
audible, Anandi.
Okay. Good evening, ma'am. Ma'am, first, when we are seeing a patient of the recurrent implantation failure, the history is very important. In the history, we have to ask about the protocol, what they have followed in the previous stimulation, and the grade of the embryos and the technique of the embryo transfer. We can categorize as whether it's a problem pertaining to the embryo or it is to the maternal factors, uterine factors. Coming to the maternal factors, we can divide this also as a maternal systemic immunological factors or the uterine immunological factors, and then also we can also evaluate the immunogenetic factors. So pertaining to the history, we have to ask about the thing of the previous stimulation. And coming to the uterine factors, you have to ask for the symptoms of adenomyosis, endometriosis, and any abnormal uterine bleeding, and thrombotic history or family history. Coming to the general examination, the weight, the obesity, and the lifestyle history all are very important, ma'am, pertaining to the history. Then if you want to move to the investigation part, we have to definitely do the thyroid antibodies, prolactins, the HbA1c, vitamin D, AMH, and the CBC, and the right. Then if we then along with that, we will be doing the transvaginal ultrasound, 3D ultrasound, look for adenomyosis, polyps, fibroids, and also the Doppler. Coming to the then at least once we have to put the hysteroscopy in the patients for the recurrent implantation failure to rule out the chronic endometritis, to look for the inflammatory signs or stromal edema, the edema, the hyperemia around the periosteum, and also the if possible we can do the plasma cell, that is CD138, and the plasma cell evaluation. Coming to the male partner, sperm DNA fragmentation test is a must in the case of recurrent implantation failure. Now, if possible, if we are in the metro cities, they are also doing the sperm aneuploidy profile also, ma'am.
Microbiomes.
Yeah.
Microbiome. Oh, sorry, ma'am. Microbiome also.
So this slide, why I have put, because now the current situation is immunology. All of us, so the moment we have two RIF, means two implantation failures, immediately means a lot of people are going for LIT and tacrolimus or thymosin alpha and all those things without looking at the basic aspects. So many centers, because these are all the investigations some of the centers might do even before the first transfer or first IVF itself. So we might be looking at, madams, all three of you, I ask whether you do a hysteroscopy as a must before your transfers. Do you do? First transfer. I'm not saying RIF at all.
If ultrasound is showing a normal endometrial cavity, and especially by 3D, you can find out even the vascularity volume. We do not do a routine hysteroscopy. Whereas about 10 years back, I would say we were doing a hysteroscopy before every IVF, 10 to 12 years back. But now we have stopped doing this for last about 5 years, I would say. So only if there is a failure or if there's any problem, we do a hysteroscopy.
But I think sometimes subtle changes that may not be picked up even with the 3D ultrasounds, like say some micropolyps or this discoloration, like pale endometrium, all those things. I am for doing hysteroscopy routinely before all ART procedures, except that when I am very sure very few of my cases, they go without hysteroscopy.
Dr. Anandi, what is your opinion?
Yes, ma'am. I'm doing office hysteroscopy a lot. So
Yeah.
definitely all my patient before ART hysteroscope I will put.
Do you do
Sorry,
a 3D study, Dr. Anandi, for these patients routinely?
Yes, ma'am. Yeah, 3D I will do.
Because 3D
As
can tell
ma'am.
you even about the vascularity, which your
Yeah,
even
yeah.
an office
Ma'am,
hysteroscopy will not tell you.
Yeah, yeah. Ma'am,
It is
3D
very, for
routinely we
some
will do.
patients, you do not, you see that there is not enough vascularity.
Ma'am,
So
not
Yes.
you
everyone
cannot
has
find out by
Padma Shri.
invasive procedure.
Correct.
Padma Shri can pick up everything.
So
So
you should have a dedicated sonologist. That's very important.
yeah, it is.
Yes, yes.
She's almost to the level of Sonal Panchal and she picks up everything. So lucky you, you don't have to do. But I'm also for
So
hysteroscopy.
Damodar gets less and Padma Shri gets more.
So I'm also for routine hysteroscopy. So majority of means I might not say the 100% of these things, but majority of these investigations I would have done even before I take up a case for the first IVF and first transfer itself. But like Asha madam said, in several centers, and not many of the investigations are done. Not even proper diagnosis has been made, and then cleavage stage and all kinds of transfers are done, and then 2-3 transfers and it is labeled as RIF, and then immediately all kinds of investigations, treatments are being done. So that route and that is not a healthy route to go about. So we have to look at all the basic parameters, and then we even have to look at the visit the lab criteria as to what happened in the lab. Dr. Yamini, so if we ask you, we had 2 transfers
Say
and
hi,
then
say hi, because people think you're not come. Dr. Divyashri has joined. I think.
So, Vani, I
Are
would
you on the
also like
faculty
to
link?
stress 2 important things that is very practical.
Are you on the faculty
BMI
link?
of the patient, I am very keen because
Okay.
in UK they don't do any ART procedures if the BMI is beyond 35, I believe. But I think that plays a major role. BMI has to be looked into. Anemia should be corrected. I am in the habit of supplementing all patients coming for ART with vitamin D because generally our Indian population, they have a deficit and it's a simple thing to correct. Correcting the vitamin D deficiency, iron, because there have been studies which shows that correction of anemia shortens the time for pregnancy.
Yeah,
So,
Dr.
and
Vani, I
of
think
course, like other
Divyashri has
lifestyle
joined.
modifications like avoiding smoking, avoiding alcohol, but even passive smoking that should be avoided.
Vani Divyashri is joined and she is on mute. She is requesting to be.
Yeah,
Yam
now
is
they have
there.
unmuted me,
Yam
ma'am.
is
They have
there.
unmuted me. Hi.
Yes.
Good evening, everyone.
Yeah.
Hi,
Yeah, good
Dr.
evening.
Devashri, welcome.
Yeah.
Hi. Thank
So,
you. Thank you.
what do you think about this adenomyosis, Dr. Devashri? Do you think adenomyosis is being missed and it is diagnosed after a couple of failures?
Few cases, yes, it is, but few cases it may be picked up in the initial visits only. It depends on what we already know. What the mind knows is what the clinician can pick up on scan. So I think we should have a strong suspicion starting from day one scan. We have to do a systematic scan to rule out all the probabilities of implantation failures. So if we do a thorough scan, I'm sure that we'll be able to pick it up. But many a times we have seen in our practice that it is missed.
Yeah, once again, I think doing a 3D ultrasound is very important so that you can see the thickness of the junctional zone. You can see the focal infiltration of
Definitely,
the junctional zone.
definitely.
So you pick it up in
Yes,
early stage because many are looking at the volume only, which is quite a late finding.
yes,
So
yes,
doing
yes,
a
yes.
ultrasound of your own is very important and a 3D ultrasound.
And there are also
Very
studies to say that asymptomatic adenomyosis does not interfere with implantation. There has been a study, there are studies to say that. See, obviously, any patient with an adenomyosis, definitely the implantation rate is about 50% when compared to a non-adenomatic patient. So that is probably because of the increased thickness of the junctional zone and the uterine contractility. And of course, there is the cavity is full of pro-inflammatory milieu, and there is very high progesterone resistance. So there can be reduction in the HOXA10, FOXA gene, leukemia inhibiting factor, and L-selectin and pinophore formation, and all these beta V3 integrins are all suppressed in adenomyosis, which can impair implantation.
Madam,
Yeah, when you say asymptomatic, I think depends on the pain threshold of the patient because girl children are taught to say that pain is natural. So they do not
Madam,
even complain when there is pain. If there's a pain during menstruation, they have been told right from childhood that it is natural to have pain. So whenever they're married, after 6 months, they come and say, just for 6 months, I'm having pain. And they already have a grade 4 endometriosis, adenomyosis, hematosalpinx, everything.
so
So
I'm not
asymptomatic
bringing the
depends on the
huge, large
cultural.
adenomyosis, what we can see, madam, but just a bulky uterus, which is asymptomatic, only on careful pickup, we can pick up this adenomyotic thing, means maybe that may not have an impact. But again, now we have recent studies which says that even we don't need to have a pre-transfer suppression with GnRH analogs. But actually, generally, what we do is only we go in for a defect suppression with the agonist or antagonist, so that the volume is definitely should be reduced, as well as there should be thinning of the endomyometrial junction before transfer.
Yeah.
So I will summarize saying that even before your first transfer, or at least after failing one transfer, do a very good assessment of the myometrium. And if there are altered myometrial signals or asymmetry of the myometrium from the anterior to posterior, and junctional zone, if your sonologist can pick up and do if it is enlarged, then suspect that there is adenomyosis, and these people might have a lot of progesterone resistance and a lot of inflammation going on, like madam said. And then maybe if we may have to deal with that before we go for the next transfer. We stopped short asking Dr. Yamini. So you started. I'm sorry, I've interrupted you. So if we tell you that we didn't get successful pregnancy, in two transfers, and if we ask you to give us the lab parameters, or if we ask you for an answer, what would you say and what would you look at in your lab?
Thank you, ma'am. The first thing that I would look into is the quality of the blastocyst that I am transferring. So, and also the number of it. Sometimes what happens even for the patients who have a good blastocyst cannot lead to a hatching one because of the thickness of the zona pellucida. So I would also look into if it is going to be a fresh embryo transfer or a frozen embryo transfer, because we all know frozen embryo transfers, they tend to thicken the zona. That could also be a reason why a good looking blastocyst, does not implant from the embryo's point of view. And another one that I would also look into is the quality of the sperm with which the blastocyst was made. See, I am looking at a scenario where not all of us are, all the patients would be willing to go in for a genetic analysis because of its cost concerns. So in that case, I would look into the sperm factor, because a sperm which does look good, as in which has a good sperm head morphology, can also harbor a lot of genetic defect or a DNA defect. So I would look into the DNA quality and also see if there's any karyotyping error that the man has already been told for. So these are the things that I would look for if that embryo is not implanted. And also what I would suggest is I would check and see if another transfer of that blastocyst with an embryo glue media or a hyaluronan rich media can, help the visibility of that embryo at the site of implantation for a bit longer than usual. So, and apart from that, if you ask me lab side, what is it that I am going to look at the culture, if I'm going to look at how it's cultured or the conditions in which it has been cultured, I would make sure that there is an uninterrupted culture, as in for a single step media, because we know for a sequential step media where I have to change media on a day 3 or a day 4, there is a higher chance where you take out the embryo dish outside and we change the media. That can by itself cause alteration in which the embryo is, exposed to. So maybe a single step media is something that I will look into, and I will also see if these parameters are considered and analyze it to understand where exactly the embryo side could have gone wrong from not implanting.
So, wouldn't you recommend the PGTA once there are two attempts failed? Would you recommend?
Yes, yes, we would recommend, ma'am. But the thing is, it is something that it comes from a patient's point of, agreement. So not all patients who come to us can afford that procedure. So we do give a chance to them. We do explain to them about the advantages of the procedure. But there are not all of them who would be willing to go for, genetic analysis. But that is something that is very much considered. And if at all, I will go for a biopsy only if I have the remaining embryos or a blastocyst to be of good quality, because we know that a B grade or a C grade trophectoderm can have a higher chance of having mosaicism. And even if I'm going to get a result of saying the embryo is euploid but minimal rate of mosaicism, there is a higher chance of it having any kind of genetic abnormality. So I would also consider to see if what is the quality of the embryo that is going to be put through the biopsy procedure before offering it to the patient itself.
Yes. So
But
it
I
is
think
again.
what you said, Vani, is quite right, because it's sometimes it's quite frustrating to see that there are 4 embryos, of which only one is karyotyping. I mean, it's a euploid blastocyst. So had you transferred other blastocysts before the best one, you would have had 2 or 3 failures, and then you will be running from pillar to post doing all sorts of tests, which are a waste of money. Maybe you'll do a ERA test, and maybe you'll do all the killer cells and all those things, and we'll be killing the money. So instead of that, if you can do karyotyping, I mean, to prove that it's a euploid blastocyst, it can make a lot of difference to our results and our psyche also.
When do you do, ma'am? After one failure or after 2 failures?
today
Maybe
what has
after
Your
happened is if
practice.
we have enough embryos, somebody is
You want to
if
go
you
to
if
first,
she has
first
formed
even
6, 7
before first
embryos,
transfer. Yeah.
I would like to suggest to them at least non-invasive NICS. And if it is a male factor, again, we tend to go for the NICS more often than embryo biopsy. Embryo biopsy is available at our center, but I still feel that if we can escape with NICS, it's good enough. So if there are 6, 7 embryos, I may go in for NICS. If there are only 3 embryos, I will go in for embryo biopsy after 2 transfers, 2 failed transfers. But young
Ma'am,
patient,
should
lot of
we
embryos,
actually
I may go even
categorize them?
before a failure.
Should we categorize them according to age, ma'am? For example, if a woman is like more than 35, more than 40, and she has so many embryos, and even if she is more than 40, but she has less number of embryos, so probably it should be tailor made. And I mean,
Yeah, so it's actually becomes very tricky. So before means we have to, that is why we have to cover all the basics, all the, like Dr. Yamini also said,
yes.
the lab conditions and how it was grown and how was the sperm and all those things she will look into before she'll recommend the typing. So because we obviously we have two
Yes.
failures and we cannot have a third failure. So we obviously have to look at everything. So if all the basic investigations were done in the first, for the first transfer itself, we are at an advantage. You know, after that, if something is failing, then we are looking at all these things, whether you know, whether we should go for ploidy testing, or you know, all the immunological testings and all those things. So once these basics are covered, then we are coming to the next level testing. Dr. Anandi has covered a lot of this testing already, like PGTA we have just covered, and embryo and gamete, like karyotype of both partners, and advanced sperm functions, like Dr. Anandi has already covered. Embryology lab audit. So that is what Dr. Yamini has told us. All the benchmarks, were they met when these particular embryos were transferred? So when we are looking for two failures, you have to go back and look at every single thing, whatever has happened, right from the we might have missed something in the history examination, and you know, all the both the couple, and like Ramni madam said, obesity and all those things. Okay, try to see whether there is any reason why these could have failed, and then we come for Ira, Emma, Alice. So what is your opinion, Ravni ma'am?
I think ERA test we were doing in the beginning, but now we have stopped doing. Okay, so and Ashray also says that it should not be done as a routine one. So now we are more like repeat hysteroscopy, biopsy, and this immunohistochemistry for CD138 plus this plasma cells we are doing, because it is very simple to do it and get the sample. But regarding the selective test like Imman, Alice, that is the uterine microbiome testing, we are, of course, we are doing it on research basis, as well as for some patients we give the option. But as you know, that Emma and Alice tests are very expensive, and it is being detected done by the NGS technology, which is very expensive. Here, the most important thing is we are able to pick up the lactobacillus dominance in the endometrial cavity, as well as what are the pathogens that are causing chronic endometritis. So by doing this testing, either by NGS, or what we do is the Prema test, which we do it by the multiplex RT-PCR. So we are trying to get the percentage of the lactobacillus dominance, and we know among the lactobacillus, crispatus is the one that has to be of the highest percentage. And of course, we get the other microbiomes like the Streptococcus, Gardnerella, Enterococcus, and E. coli. So that's all. We compare it with the percentage of the lactobacillus. So then we get the sample sensitivity of the antibiotics. We do give the patients antibiotics, not a blind antibiotic, because most of the people are in the habit of giving routine doxycycline for correction of chronic endometritis. But I say that should be given for a period of minimum 21 days, and metrogel can be combined. And sometimes in resistant cases that and at the same time we have to supplement these patients with the prebiotic and the probiotic. That is very important. So probably with one testing or two testing, twice, second testing, almost we could have achieved the depletion of all these pathogenic organisms, and the lactobacillus would have increased. But we can't expect a 90% of lactobacillus in the uterine cavity. And even if we reach the 50 to 60%, that is sufficient. So once when it is reached, maybe we can go in for a transfer. Okay. So that is what we practically do in our center for regarding the correction of uterine microbiome and chronic endometritis.
So once we correct all the basics, and then we think go on look at the lab and think whether we need to do ploidy testing and genetic testing of embryos. Then we are looking at uterine microbiome, and we are thinking of ERA. Ramni madam is not doing. Madam Asha ma'am?
ERA test we were doing in the past, but not now.
No,
yes,
Asha
today I feel that instead of spending on ERA test, you may as well do a ploidy test before transferring. Same money can be diverted towards this. Because once you're sure that it's a euploid blastocyst, everything else you can forget.
Dr. Anandi and Dr. Divyashri, what do you think about ERA?
Regarding ERA,
I'm asking about
I think
practice.
we have a lot of articles showing about saying about end of ERA. And one thing what we have to understand is we are not looking at a point of implantation. It is a window of implantation. Window means plus or minus 1 or 2 days. So I don't think it doesn't make sense to chase that point of implantation. And here there are various studies which have proven beyond doubt that it is the embryo which is the main key factor controlling implantation, not the endometrium to a large extent. So ERA definitely has no role, and I think most of the Western countries have discarded ERA, but I think in India we are still holding on to. But it's very important for us to practice evidence-based medicine, and we should get rid of ERA. I think it is high time.
I agree with you. I can't. I'm
It's a very nice
totally
caption
happy.
You said end of an
Yes.
era.
End of era. End of era. Yes, very nice. Dr. Anandi, do you also feel that, or do you have any difference of opinion?
No,
Just
ma'am.
I want to say that I really like saying end of era. It doesn't give us much value at all. Even I was doing so many, wasted a lot of money, I think, sometime back, some years back. Then I stopped after that. Sorry, Anandi, you said something?
No, ma'am. No ERA. Only in my RAF patient, I will be going for PGT.
PGT. Okay. Everybody is very strong on PGT. Okay. Okay. So immunology, there are so many immunological investigations. Dr. Anandi has already said there are so many immunological investigations you can do. Peripheral NK cells, uterine NK cells, in the peripheral blood Th1, Th2 ratio, Treg T17 ratio, and then HLA. So these are all the HLA and KIR. So these are all the immunological tests we have right now. We already they were spoken by Sir, Dr. Ramkrishnan Sir, and again we'll be touching on it on almost on all the cases. We'll start off with one case, 35-year-old 2 failed transfers of good morphology day 5 blasts. All embryos PGTA confirmed euploid. Transfers performed in HRT prepared cycles. AMH normal, AFC normal, husband semen parameters are normal. Transvaginal ultrasound is normal. No prior uterine instrumentation. No symptoms of pelvic inflammation. Thyroid, prolactin, glucose, HbA1c, everything normal. So, oh, sorry. So, what are all the tests you want to do? Asha ma'am?
This lady somehow you said she has pelvic pain prior to menstruation. So I
Yes.
would definitely like to rule out adenomyosis in this patient because it's undiagnosed many times. So definitely maybe down-regulated cycle sometimes may be helpful. 1 or 2 cycles of down-regulation before transfer could be helpful. That's number one. Number two, I would like to repeat a hysteroscopy mid-luteal and take a biopsy and rule out chronic endometritis. Because sometimes you may see polyps, which are a feature of endometritis, and treating the disease can perhaps improve the pregnancy rates, though there are controversies. There are papers which say that it does help, it does not help. But then a repeat hysteroscopy and a biopsy for CD138 also would be helpful.
Okay, so would you do only look for adenomyosis and look for uterine inflammation and then transfer, or would you also do some immune profiling? Because this
no, yeah, as
this
mentioned
one
earlier,
had
APLA, etc., we would have done earlier itself. APLA and
APLA.
ANA we do before the first embryo transfer itself.
Okay.
And
Thyroid antibodies
we are
also,
not
will
yet,
you do?
thyroid antibodies also we are doing after 2 failures.
Okay.
But we are not yet into the NK cells and HLA.
Ramni ma'am?
Yeah, I don't do routine APLA testing because we supplement at least for the first initial till the implantation, till the UPT becomes positive, we give the patient heparin. Okay. And antithyroid antibodies, yes, we do as a routine because we find a lot of these patients getting positive with just an antithyroid antibodies are positive in many of the patients.
Dr. Anandi and Dr. Divyashree, what do you think? What do you do as an immunological profile before your first transfer? Is it APLA? Is it thyroid antibodies, or do you do advanced immunological profiling?
No
ma'am.
advanced.
No advanced.
No advanced.
Yeah,
Yes,
we
ma'am.
do
Routinely
APLA
we will be
before.
doing.
Yeah, we do APLA before the first transfer. Maybe after a couple of failures, we'll do the thyroid antibody. And NK cells will be the last in our list. We're not doing it.
I'm also doing thyroid antibodies before first transfer, and APLA, unless there is symptoms, I'm not doing yet. So in this case, after 2 transfers, we know that there are some symptoms which are indicating that hysteroscopy and endometrial biopsy and studying the endometrium is important. But are we going to do only that, or are we going to do some advanced immunological profiling as well in after 2 failures?
Ma'am, after 2 failures, what I will do, instead of going for the TH1, TH2 balance, that and all, it's a little bit costlier. So simply I will do one screening, that is TNF alpha. And if the patient is affordable, then I can go for the cytokine profiles because it's costing only 5,000 rupees, I think. The TNF alpha is only 3,000. So I'll screen at least one immunological profile like that. After that, we have already done TPO antibodies routinely. So after 2 failures, if you want to go for immunological profile, instead of going for very costlier things, at least we can do some screening.
Yeah. So I think I agree with you. We have to I don't know, after 5 years or after 10 years, our thought process might change. But right now, our brains are full of immunology and so much of immunology and what it can do for our poor embryos. So some kind of immunological testing, either peripheral NK cells or if you are doing CD138, you can go ahead and do a CD56, which is uterine NK cells, or something like that. All these are 20,000, 25,000 and 15, something like that. So we can, our HLA matching to see if there is something going wrong, because we have eliminated everything else and we can't afford to have a third failure. So that is why we need to look at some kind of immunology as well. So this was looked at. There was
Sometimes maybe a
dysbiosis
stimulation itself, or many patients are coming from younger centers, where somebody who had just passed out is doing a stimulation. So whether they gave
yes.
antagonists at the right time and what kind of stimulation they gave, all this makes a lot
Yes,
of
ma'am.
difference.
So
Yes.
So instead of
once,
spending all your money on immunology, maybe do a good second stimulation,
Polyclinics, yes.
and
yes,
at the
ma'am.
most do a ploidy test. Maybe you are successful.
Yes. So we have to look at the basics first. So that we have visited. So this is couple we have investigated and we have stimulated, we have transferred, we have done so many things even before our first transfer. We have got 2 failures. So that is where we are sitting at. And so there is dysbiosis and some immune dysfunction as well. So how do we go ahead and treat this? Who wants to take it up? Madams, anybody?
If there is a there is a proven immunological problem, as Sir has told, no ma'am, routinely we can give that HCQ 200 mg BD. Then aspirin, ecosprin, what we all will be routinely giving along with that, along with the heparin, aspirin, then HCQ. What I am giving is the intralipids, ma'am. When there is a immunological problem, I'll be giving the intralipids once in 2 to 3 weeks.
Asha ma'am, would you give anything else? Steroids or?
Steroids, yes. Yeah.
Oh, no. As most of my patients are on anyway low molecular weight heparin. That is the routine. And whenever there are a couple of failures, if ANA is positive, we definitely put them on HCQS. And one of my patients who had one failure, and she used to get thick endometrium. We gave her in fact, we gave her a Mirena for 3 or 4 months, and we took out the Mirena. Then again tried doing a frozen embryo transfer. The endometrium was thick again. And then the girl said, we were again worried, how we can go ahead with this thick endometrium. And that girl said, no, instead of all that, just do my IUI. This was the suggestion which came from the patient. And this patient has now conceived with the same thick endometrium. I think the endometrium was 1.5 centimeter. And she has conceived with IUI, and now she's term. So had she not conceived with us, we would have spent a lot of money on immunology. So I think I wouldn't like to spend too much money on immunology unless I do a couple of transfers and also the ploidy status of the embryo.
Well,
and if it is the adenomyosis, I would like to treat. If it's a thick endometrium, I would like to treat. If it's a thin endometrium, I would like to treat. All these make a lot
yes,
of
ma'am.
difference.
We have to touch immunology once there is nothing in the pelvis. So pelvis is absolutely normal, uterus is absolutely normal, and sometimes we would have done ploidy status as well. And then when we are looking to see why euploid embryos are failing, so that is That is where this immunological status comes in. But when we are looking at the third attempt, a little bit of immunological factors probably becomes in this current era, we probably will look at. So probiotics and antibiotics, like Ramni Madam said, we will give. And steroids, intralipid, and a good amount of progesterone, because that is also a very good immune modulator. Vaginal progesterone is very, very important. So like Asha Madam said, it is there is so many immunology is being absolutely misused. I totally agree with you, ma'am, because I have seen a lot of people who are getting LITs and all the things which have been done. So I was not going in that thing at all for a long time. So after some time, then I was curious as to what is happening. Then I've started learning, and then now I have few patients who fall into this category of I've done everything, I looked at everything, but then still they did not conceive, or they were losing their pregnancies. So that is when I started employing all this immunomodulators, doing HLA testing and all those things, and then trying to give good the right kind of immunomodulation after doing the testing. So we are treating both here together. Chronic endometritis, like all panelists have covered beautifully. Like we have to look at to see whether lactobacillus is there, whether abnormal pathogenic bacteria are there, and the percentage of lactobacillus, and then try to treat it. So that is one very important thing before we go ahead and do anything else. Emma and Alice, they look at lactobacillus and pathogenic bacteria, and Dr. Ramni Madam has got a Prema study going on. She looks at all the pathogen and lactobacillus in her model. If you want, you guys, you can contact her, and she has got something like Emma Alice. She has got Prema. So the next case is 32-year-old female partner, 35. 32 female and 35, and 2 failed transfers, all good morphology embryos. 2 spontaneous early miscarriages, that is biochemical. AMH, AFC, partner semen parameters normal, hysteroscopy normal, APLA negative, thyroid normal, CD138 negative. PGT was not done. Fertilization rate consistently 70%. Blastulation rate was normal. What do you want to do? Dr. Anandi?
Ma'am. Sorry, I have not.
Okay, so everything seems to be normal. Two embryos failed.
So since she gets good number of embryos, and possibly she is a PCO, and she gets so many embryos. So it is definitely worth doing the PGT, because she had no PGT done in any of the prior cycles. That's one. And again, look at the fact whether it is a thick endometrium, because she is a PCO also. What is the vascularity? Do a good 3D study, and that also can give you some clues.
Dr. Divyashri?
I think in this, even though it is 2 pregnancy losses, it's a good idea to do couple karyotyping. Many a times we may be missing something like translocations, which could be Robertsonian or reciprocal, where it will be very obvious for us. And if couple karyotyping.
Yes, that is why Asharao Madam.
Better I think we will go. I will go for PGTA.
PGTA, yes.
Yeah.
Okay, so Divishri, we can't hear you, doctor.
Balanced reciprocal.
So husband has a balanced reciprocal translocation. So Dr. Yamini, everybody wants to do karyotyping, obviously, and then karyotyping is given us the the culprit, which was the culprit all through. So what do you think? What will be the yield of PGTA in this people?
And what would be the
Yield, like how do we go
okay,
about?
the aneuploidy. Okay. Ma'am, in this case where we do have an information about what is the quality of the genetic makeup of the husband's karyotype, I think a PGTA would just give the overall information of the already known fact. So instead of going for a PGTA, I would also go in and understand if there's any kind of a specific mutation, a gene mutation that can be analyzed using a specific PGTM, where we can understand if that defect is being transferred into the blastocyst also, and that could be a reason why there is no implantation. Yes, of course, PGTA can be done, but I think a more specific result, analysis of the biopsy can give us more information if that embryo can be used or not. So, because we will be having good number of embryos, we can make the patient understand if they are willing for a biopsy, and if they are, I think it is a good enough option, ma'am.
Yamini, PGTA or PGTA, sir?
I think
no, I'm sorry.
I have
For
little bit of
structural
difference.
abnormality, yes, sir.
The structural abnormality, yes, the aneuploidy will not give us more information about the already existing, defect that we have found through karyotyping in a husband.
I have little bit of difference of opinion here. See, PGTSR is definitely indicated in this case, and common things are common. And with 2 previous abortions and having a translocation, that is the cause. PGTM is definitely not an indication in this case, because if we have to do PGTM, then it will be like searching for a needle in a haystack.
Okay.
We will be totally lost if we do PGTM in this cases. PGT-SR is definitely an indication in this case.
So PGT-SR we will.
Yes, sir.
Okay. If the embryo turns out to be balanced, would you recommend transfer, Dr. Yamini?
If we do not have any other embryo that has post, it to be euploid equivocally, and we have left with just this embryo, which has still given us information that their structural abnormality is not found, I think it is a good enough option to go in for a transfer.
Yes.
But we'll tell them that their reproductive career might, again, they'll have to go for PGT-SR.
PGT-SR.
For that child, right?
Yeah, one of my patients, we transferred an embryo like this because there was no other embryo. Then she conceived, but then she went in for an early pregnancy loss. By 7th week, the 8th week, the effort stopped. So then the father-in-law was upset. Why did you do that? We would like to do one more pickup rather than go in for embryos like this. So
okay. That is another option.
We have to counsel them thoroughly. That's very important.
Yes.
So
we're doing it for your sake and not for our sake.
Okay. So have more embryos to see whether we can get at least 1 or 2 normal embryos. And after counseling, probably we can decide whether to transfer this balanced. So we have done that. And then third case, 35-year-old secondary infertility, 4 failed of early miscarriages, early miscarriage 4 years ago, 4 failed transfers, all embryos of good morphology, 1 PGTA, euploid blast, AMH, AFC, everything normal, partner semen normal, hysteroscopy normal. ERA test reported as receptive. I don't do ERA. This is so we can ignore that. CD138 negative, and patient frustrated. Every test is normal. So I'm adding we have a euploid blast. So previously with the euploid, the ploidy status was not checked. So we did the karyotype, and then we found that the partners had a genetic problem, and then means it was pretty straightforward as to what to do. So here, what shall we do?
She
Here
had
we are
miscarriage
having a
earlier. So you
yeah.
could think of APLA or antithyroid antibody.
So here we are thinking of, so we have ruled out all the basics. Again, I'm telling you, ruled out all the basics and looked at the embryo data. We have looked at the euploidy data. We have looked at 3D ultrasound and ruled out the adenomyosis, ruled out the uterine inflammation. Now we are looking at immunological profile. So immunological profile. What are the immunological? Okay, imagine she can afford. So what are all the immunological tests you want to do, Dr. Anandi or Dr. Vishri? I wouldn't trouble
Madam, here, as you can see, there is only one PGTA euploid blast among them. So
Okay.
there is definitely a hint. Out of how many embryos, only one PGTA euploid embryo was
No,
there.
actually, what I meant was ploidy status was also checked. Kindly read
That's
it
right.
like that. Sorry.
So one
That
PGTA
means that
euploid blast is
aspect has been covered. Even she rejected even euploid blast. That's what I'm telling you.
So,
Yeah.
so
Please.
how many euploid embryos she rejected, madam?
Okay, here I'm saying one, but now I'm changing it to two.
Ma'am, because that incidence is very less, and it is very clear with all the evidences. One is with Perita, and the other one is Gill in 2024. The true incidence of recurrent implantation failure after 3 euploid embryo transfer is less than 5%, and after 5 euploid blastocysts, it is less than 2%. So, in those.
Yeah.
I'm a little skeptical that really did she have 3 euploid blastocyst transfer failures, and if at all she has had 3 euploid embryo transfer failures, then we should think why even a euploid embryo is not implanting, which means it what we are looking at is just about cytogenetics, but we are not even looking at the cytoplasm. So most of the times it could still be an embryo problem. I still don't think about doing any immunological investigations in this point in this patient.
Excellent. You have your point, and then those articles I think came out about 5 years back. That euploid blast. If you have euploid blast, you have 95% after 3 transfers, and then after 6 transfers, maybe there is no, there is absolutely nobody will. I mean, almost everybody will. But there were only 2 papers, and then it was not replicated, and now those papers are being questioned. Whether there are so many conferences which is being held on when euploid blasts fail. So that means they are looking at least 2 or 3 euploid blasts, and then we have even if it is a tiny situation, we have a situation where euploid blasts may fail. So two euploid blasts have failed, and then we want to look at the other aspects. So you want to look at the cytoplasm of the embryo. You want to look at the mitochondria of the embryo. You want to look at the stressed status of the embryo. So I totally agree. It is like, I'm not saying we have to do immunological testing and we have to do HLA testing, and that is the only way we are going to get a positive in the 3rd attempt. No, I'm not saying. So there is a good case for looking more deeply into the endometrium. Now we can embryo, we can, once we have a biopsy of the endometrium, we can look at the mitochondrial status of the endometrium. If it is high, we know that endometrium is stressed. And if it is a little bit aged, and we know that if we can transfer the donor mitochondria, that embryo might implant. So try to concentrate on the embryo. Good. I agree with you, and I also think that maybe there are few people. Maybe we need to look at the immunological status. We might be keep debating about this, and then it's not that one person is right, one person is wrong. We'll try to look at all aspects. Okay, we'll try to look at more and more and more into the embryo, and probably we'll look at a little bit into the immunology aspect. In case if we decide to look at the immunological aspects, means Dr. Divyashree, obviously she's not going to test. I'm just joking, Divyashree. Please don't take me wrong.
No, madam. No, madam. It's not like that. See,
Okay.
the thing is,
No,
it is not
I'm not
about
saying it
testing the.
is. Yeah,
No, no,
yeah,
it's not
I
about testing
understand.
the cytoplasm. It is not about testing the mitochondria or transferring the mitochondria. What I'm trying to tell you is, even if you do an immunological investigations, we may not reach anywhere. We may still be revolving around the embryo, where we are still not able to test it. So we may have to think about other options. And even if we do some immunological testing, are we going to act on it? Because immune system is something which is not targeted at one. It is an orchestra of events, and it is the orchestra between different modulators of implantation. So are we doing justice in suppressing this inflammatory process by suppressing the immune response? Is something that we have to introspect, because implantation is akin to inflammation, and depending on these immunological testing, if we just suppress the immune response, are we doing justice, is something that we have to introspect.
No, it is not immune suppression, it is immunomodulation.
Modulation.
So we are looking at modulating her immune system. I agree with you. We have to look at this immunological treatment in a very skeptical manner. I totally am with you. Okay, let me say I am looking at a little bit of immunology in my personal practice as well. Anybody else? Dr. Anandi, Ramni ma'am,
Yes.
Rasha ma'am, are you guys looking at any of the immunological parameters and then trying to do some kind of immune modulation?
No.
Yeah, ma'am.
Oh,
Yes, ma'am. The implantation is not just with the quality of the embryo. There are so many things. It has to roll, it has to attach, it has to adhere, then it has to bury. Then the synchronization between the endometrial, the NK cells and this trophoblast, the NK cells has to allow the trophoblast to bury inside the endometrial stroma. For that, the cellular activity, if we are having a good ploidy embryo, then we have to have a look on that thing, whether it is immunological or inflammatory response, anything, we have to definitely have a look on the immunological thing also, ma'am. We can consider that.
Can
We
I
should
say
consider.
something? Can I say
Yes.
something?
Yes, ma'am.
We are doing an immunological profile, but it is part of research. We call this as endometrial immune profile, in which
Yes.
we do the like 4 basic tests from the endometrium, which is almost like on the at the time of implantation. So whether it is overactivated, underactivated, and that's the other thing is we are doing it in surrogates as well, which is proven implantation. We have got the interim reports in which the surrogate reports were totally blinded, in which it has come as overactivated immune response or underactivated immune response, but we didn't intervene. But in spite of that, they did have good implantation rates, pregnancy to term, and delivery. But in patients who had altered immune profile status with recurrent, the real recurrent implantation failure, which means we also had transferred PGT and normal embryos. So in those patients, even though we did transfer depending on the immune profile status, we did not find any difference. So this is what I'm trying to tell you, that even though we think that okay, we are trying to do something, immunology is something that we totally don't understand. So this is this is going to be presented last year. This was presented in ASRM, and this time again it is going to be presented in ASRM with bigger data. So this is my personal experience on immune testing, both in surrogates and patients with recurrent implantation failure.
last year, yesterday, there was a paper which they started looking into. That is, embryo implantation is a black box, and then immunology is the one which plays a large role. We may not know. We may not know the exact sequence of events in the black box, but we sort of are trying to understand what are all the sequence of events, and then trying to see if we can do something about changing those sequence of events. And there was a paper, means there was a oral presentation which said there are certain tests which will tell you that the woman is in a hyper state which needs to be suppressed, or a woman is in a suppressed state which needs to be who might need to be activated. So that was by a very, very senior person. I just not getting the name. She's done at least she's almost 60 or 70 years old, and then she has done enough number of research. Now she's telling that there is something like, you can do some amount of immunological testing and then find out, instead of blindly. That's what, right from the slide one, I'm telling, it is not blindly just because we have lost. We have to this thing immediately. I'm not saying do LIT, do this, do that, but in some patients probably there is a scope. I don't know what to say. Senior madams, Dr. Amnidev Madam, Asha Ma'am, and Dr. Diveshri are not, means they don't agree that the immunological, but audience, you have to listen to everybody and take what senior madams say, because they have been doing this doing this transfers and then all these things, because they didn't probably find it useful at all in this practice, so that is why they're not doing it. So please listen to them. And Dr. Diveshri also is giving a lot of good
The
explanation.
science is
Why
continuously evolving, Dr. Vani.
Yes,
So
yes,
what
yes,
is
ma'am.
false today will be true tomorrow.
Yeah.
That's
So
how,
I'm just
we
saying,
did not
telling
believe
them
so much in
so
doing
that
a
they,
PGT about 5-6 years back. I never
yes,
believed so much in spending money on PGT. Now that it's easily available,
yes,
we are saying yes.
yes.
So I'm sure, whatever we did not agree with today, as the research evolves and something better comes, we will definitely agree. We do not have any rigid policies.
No. I'm just saying at this point of time, like I said,
I know.
yeah, at this
Because
point of
we are
time.
worried about how much the patient has to, empty the purse.
Yes,
That's my
yes,
concern.
yes. That is a very, very thing. Because if we tell them that this all thing can be done, and tomorrow everybody will start doing all these tests for everybody, even before the first transfer, somebody like me might also be doing even before first transfer, and then try to burn all the
We have
money.
brought out you have brought out very nice points, and I'm sure as the time progresses, many more things are going to evolve.
Yeah.
And also regarding the availability of the test also. As we go higher and higher, maybe the cost will come down. So the audience should go with the idea that the basic test should be done first, and all this immunological thing, maybe under research setting, we can do it. And maybe in future, as Asha Madam said, what is correct today may not be correct tomorrow.
Yes.
We might expand our array of investigations.
And similarly, instead of doing so many tests for Alice, Emma, and Prema, we may like to give doxycycline empirically, and also maybe lactobacillus empirically, if it can save a lot of money for the patient. Because in
Dr. Ramni
India, I think
Madam will
money
not
makes a
agree
lot of
with that.
money
No,
makes a
see,
lot of
what we have
difference.
done is, I might come up with my data. Like initially, we were using empirical thing. Okay, like putting doxycycline and metrogyl. But after getting to know this, probably we should think about proper evaluation. But Prema study is not that expensive, as Alice and Emma.
So, yes. So I'm very happy that so many points are coming up.
Can I
So how
can
we
I
are
just
evolving.
can I say one
Yes,
point?
yes, Divya.
Yeah. So, why all these investigations came? Why so many evaluations came? Let us just understand that. Because every time something fails, we are met with a question that, doctor, what are we going to do next? So it is about, okay, what are we going to do next? But let us understand embryo implantation is a combination of endometrial receptivity, transfer efficiency, and embryo, the efficiency of the embryo. If you look backwards, transfer efficiency, I think we have mastered with soft catheters and ultrasound guidance. The second thing is endometrial receptivity, which is probably is also not a very common problem, whether it is natural cycle or it is HRT cycle, and it is adequately primed with estrogen and progesterone. I think most of it is taken care of. But what is the rate limiting step is embryo quality. Even in spite of embryos being normal with euploidy, we don't know why embryos fail to implant. So, but that does not mean the second
So
time
you
embryo
agree
transfer.
that euploid embryos don't implant, Dr. Divashree?
Yes, absolutely, absolutely,
Yeah, once in a while,
absolutely.
yes.
Okay,
Not
okay.
Yes,
always.
Okay.
yes,
No,
because
and do you agree that aneuploid embryos also can implant?
Yes.
Yes.
Otherwise, how can
absolutely,
you have
But they
defective
yes,
often
babies?
land up with
yes,
miscarriage.
yes, yes.
Yes.
So,
So
if
aneuploid embryos
the
implant, euploid embryos don't implant. So it is
that
not only
depends.
ploidy, we have
ex-
some other factor. Right.
Exactly, exactly. That depends on
Yes.
the selectivity and receptivity of the endometrium as well. So
Yes.
that
So
is why the spectrum
where
that
does this selectivity come from? Where does this
it
receptivity
is,
come from? It is
it is the
immunology and
Yes.
immunochemicals which are
it
directing the endometrium to, okay, come take it or don't take it. If it is an over receptive endometrium, it is HLA, AA, it will take up all kinds of nonsense, and then the embryo cannot grow, and then you have
so
lot of
it so
miscarriage.
it is the
Yeah.
selectivity and receptivity which
Yes.
at this point of time we cannot measure. That is what I want
We
to put
can,
it
we
across.
can. We are. Maybe I wouldn't say halfway. We are somewhere there. We are somewhere there. We are
So
in
that
that
is why
stage.
it should be part of research, madam. It should not
Yes,
be.
yes,
Uh,
yes, yes,
it should be
absolutely.
part of research. It should
Yes,
be
yes,
part of
absolutely,
research.
absolutely. And a lot
Yes.
of people are doing research and a lot of people are publishing. And then
Yes.
by doing this HLA, HLA of both parents and then HLA of the endometrium, they're able to say at least to certain extent. So this is a over-receptive endometrium. It will take up all the trash that comes into it, or it doesn't have the capacity to reject also. It takes up everything, and there are some resistant endometriums. Even if good euploid embryos come in, they may reject. So that is HLA, that is genes. So genes act by the chemicals. What are the chemicals like? That INF alpha and cytokines and all those things. So either we might measure these cytokines or in NK cells, or we measure the genes itself. So measuring this, we have little bit more knowledge as to why this rejection is happening, right? Okay.
So it
So,
should be part of research, madam.
okay.
Only
I
research.
agree. I agree
We
with you.
cannot we cannot advise this as a therapy.
No, I
It
am
should
not.
be part of research.
Okay, research. So I agree that we have to. I'm really happy you're insisting on that. You're, even though I'm trying to raise my voice, you are not falling for me. So I'm really happy with you, Dr. Divashree. You're standing on your ground and saying that immunological therapy and immunological investigations are research. It should be treated as research, and it should be treated as a therapy. We have to be very careful before we embark. So just because there are two losses, don't jump and do all kinds of therapies. So these are all the investigations, whether if we want to do TH1, either the genes directly or HLA genes, or you investigate the cytokines and or investigate the NK cells. So based on that, you will know what kind of this thing is happening. And I think we are running out of time. Should I stop here, Dr.? Should I stop here, madam? Ramni ma'am,
You just summarize what you did for this
Yes,
patient.
ma'am.
Yeah.
Concluding remarks, if we can have.
Okay. So TH1, TH2 was done, and then peripheral NK cell percentage was done, and HLA C typing and KIR typing. NK cells were elevated. TH1, TH2 was TH1 dominant. Haplotype AA with paternal C2, which is a high risk combination. So even if we have high risk combination, because these genes act through the immunological parameters or immunological bodies, or so we can tweak or we can modulate this immune response and get a good response in spite of we having a bad C or bad C and A. And I did have, means I just started all this recently, and then I have 2 pregnancies successfully going on, mostly on GCSF. They are on GCSF, and with that, means they had quite a few losses, and then now the 2 pregnancies are safely going on, and then I'm literally thanking my GCSF. So the patients are also thanking GCSF. So that is when I started thinking maybe there is something to this, and maybe we should understand. And then I'm not saying everybody should start treating everybody with all these things, but just try to understand whether there is HLA matching between mother and father. If there is too much of matching, then only you should think of LIT, but otherwise no LIT. No, it is not a routine thing at all. But look at the immunological parameters. If we have lot of inflammatory markers, then, or bad C and KIR, all of you know by now that there is a different combinations which are available, good combinations and bad combinations. Then we can modulate this with this one was done with tacrolimus and GCSF. I'm using right now GCSF every day, 100 micrograms every day, and then one person I've taken up to 12 weeks. I've continued till 12 weeks, and now I'm going to stop. The other one is some 7-8 weeks, and the other person I've started on tacrolimus, and then just started coming positive. But maybe I will tell about this one. So here they have given tacrolimus, and then low dose aspirin and GCSF and prednisolone as an immunomodulation. So these are all the immunomodulators.
How do you give this GCSF?
Madam, we have that GCSF vial, no, ma'am.
Yeah.
We load it into the this insulin syringe.
Okay.
And we tell them that how many units to take.
Okay.
So every day we'll load and give it to them, and they will take every day by themselves.
Okay, it is it is subcutaneous or
Subcutaneous.
Subcutaneous. Okay.
Subcutaneous.
Okay. Okay.
I think I mean, again, I should not say with 2-3 cases, I should not say that everybody should start using it. There is a very small percentage of people might benefit from all this immunomodulation. So these are all the immunomodulators we have: prednisone, dexamethasone, methylprednisolone, intralipid. Intralipid, a lot of people are using. Actually, I don't use much of intralipid. I don't know. I never had a habit of using intralipid. IVIG, we know it deals with all kinds of inflammation, but it's very expensive. A lot of people are not using. So at this GCSF, I'm happy with. Tacrolimus, I'm happy with as of now. So to start, if they need high level immunomodulation, not for everybody who has 2 losses. I would have ruled out everything which we have spoken for the last 1 hour or more than 1 hour. I'm not even counting the time. So I still have all those things, but I will stop at that. Thank you very much for an interesting panel, and Asha ma'am, Ramni ma'am, Dr. Anandi, Dr. Divyashri, Dr. Yamini, It's been a pleasure interacting with all of you.
Brought out such lovely points.
Yeah.
And it made me read for last 48 hours. So every time we attend a panel, I think we are extremely benefited. Stimulates our brains, and we can seriously think of introducing whatever you have discussed today. Thank you.
Thank you so much, ma'am.
Thank you very much, ma'am. Thank you.
Thank you.
Thank
Dr.
you, ma'am. Thank you very
everyone.
much.
Thank you, ma'am.
And
So
thank
now
you,
we are at
Kundavi,
the
for
fag end of the webinar to deliver the vote of thanks. At the outset, I wish to thank all the panelists, Pani Pujari ma'am for being an excellent moderator, Asha Rao ma'am, Ramani Devi ma'am, PG Anandi ma'am, Divyashri ma'am, and Yamni ma'am. Your panel was worth studying more than 10 textbooks or revising all the guidelines. You went through all your ample experiences and added evidence to it. Thank you very much, ma'am. I want to thank our HOD, Dr. Kundevi ma'am, for giving us this excellent platform to bring all the eminent speakers throughout our country together this evening. And there are many attendees still attending the webinar. That tells us the quality of this program. I thank the other speakers, Dr. Anuradha Udimudi ma'am, Dr. Ramakrishnan sir, and Dr. Naina Patel ma'am, who agreed despite their busy schedules and came for the talks at the prompt time. I thank Sahiti Priya of Shield Connect for the technical support. I thank our Secretary Vidya and Magesh for the support from our side. I thank all the attendees for having an interactive discussion, and I hope the same support from you in the respective coming webinars too. Thank you very much.
Thank you.
Thank you very much.
Thank you, Kundavi.